Welcome to the Coli Institute Uveitis update virtually. Obviously, it's been a crazy couple of years for all of us here, but we thought we could do this virtually and share some of our excitement and fun that we have when we talk about cases with the audience out there. So we usually do these courses in Cleveland as well as at Academy, and we thought we'd do one virtually and share our cases with everyone. Let me introduce my faculty, starting with Corrine Louder. Corrine needs no introduction. Corrine, you want to say hi?
Hi.
We have Sumit Sharma, also here at the Coli Institute.
Hello.
The man who needs no introduction, the one, the only Dan Martin, the chair of the Coli Institute, sir. Thank you.
Hello.
And special guest flown in from New York, former fellow. We're very excited to have him here. He is just as crazy as we are. Congratulations, Yasha Modi from.
Very special being here.
Yasha Modi from NYU. So it should be a lot of fun. And thank you to Sean, who's helping us out today. We're going to talk some really fun cases and go through them. I think it'll be. We'll all learn, and I'm pretty sure we'll argue a little bit, and we'll criticize my presentation skills. So it'll be great. All right, so I'm going to start with a 59-year-old male who presents with decreasing vision for the past 3 months. Was previously seen by a neuro-ophthalmologist who noted optic nerve swelling, had an MRI and an LP done. The LP showed elevated proteins and some antibodies, all right, IgG. There were lymphocytes as well, and the patient had a continued workup because the patient's HIV positive. His CD4 count is greater than 400. May have had a history of a ruptured globe in the past. We weren't really sure. He has no allergies, no family history. He's a man who has sex with other men. So when we look at his medications, he's on Genovia. That's really probably the only relevant medication that we're on. So no tricks so far. He's 2400 when he shows up to our office in his right eye and 2030 in his left eye. We didn't see an afferent, at least at this time. This was a technician who checked it, so I can't confirm this is absolutely 100% true. 2+ cell, though, in the right eye with KP, and 3+ cell in the right eye and 1+ cell in the left eye. All right. So let me show you some pictures. So here's the picture of the right eye, and we're going to describe these here in a second, but I want to show everyone here what we see. Here's the right eye. And just a close-up of the right eye, a pure picture, Dan Martin, Dr. Martin, 30-degree just of the nerve. That's all you need. They don't need to see anything else. You're good. So he's super excited, even though he can't see anything. And there's the ultrasound just showing you the nerve elevation. But I'm going to show you the left eye here. And then let's talk about the photos here, because I think that's the interesting thing, and then we'll get to other imaging here in a second. So Yasha, I know you're dying to tell me everything you know about this case. So go ahead, Yasha. And I want to tell the audience right now, Yasha has not been shown any of these cases. These are pure cases. We're gonna quiz him for the whole time. Go ahead, Yasha.
I mean, there's an incredible amount of vitritis here. So when you look at the vision loss, I think this level of vitritis can certainly account for that, but we also know there's disc edema, and then there's sort of these multifocal peripheral, deep white lesions, which certainly are very, very concerning in this case. And in the left eye, while the exam looks relatively normal, there certainly does appear to be vitritis on that fundus photo. There's also disc edema. There's some nerve fiber layer hemorrhages. So certainly this person has bilateral disc edema, bilateral asymmetric vitritis, and then these sort of choroidal lesions in the right eye. And all we have so far is essentially some neuroimaging and an LP in the absence of any laboratory workup.
Yeah, so I'm going to get to that. I'm going to tell you, and I'm going to show you a lab piece in a second, that he was being treated for Lyme disease. He did have a lab workup, and he got positive for Lyme, so he's being treated for Lyme disease. Sumit, go ahead, sir.
So I think that.
Oh, sorry, Dan. I apologize. Sumit wants to say something first.
Don't,
Sumit, you don't have a job after this. That's fine. Interrupting the chairman. Yeah.
We're good. I just wanted to point out one other thing.
Yes, sir. On the right eye.
No. Go back.
It's in the
go
left
back to
eye.
color. So
Yeah.
the left
That's
eye.
what I was going to say too.
So inferiorly along the arcade, there is this sort of ground glass appearance of the outer retina, and that is virtually pathognomonic for a certain condition.
Okay.
I actually think it extends into the macula superiorly.
so
I think
do
it's
I.
even going higher. Yep.
Yep.
Do you have an OCT?
Yeah, we do. I'm going to show you everything. I'm just showing you first the fun spot. Corrine, do you need any other photos in your mind at this point in time? You're pretty good. Just from let me ask Corrine your thoughts on when this person walked into my clinic and I was told they're coming for an evaluation because they have Lyme disease.
Well, this patient is HIV positive. he has sex with men, and I would think of syphilis as the diagnosis here.
Yeah, and I think all these findings that we're pointing out here are pretty classic for syphilis, either isolated by themselves and certainly with the history. Go ahead, sir.
But just for fun, let's go back to the right eye.
Yeah, this is all fun.
Let's say the left eye was normal.
Okay.
And you had a patient who presented with these multiple spots. Now, that is very typical of what you might see in syphilis. But what else could it be? So, anytime you see something that involves that much of the peripheral retina that's just starting, it could be an early ARN. I don't think it is. It doesn't look like it, but it could. You can't. If this is the only thing you had to go on, you couldn't say that with 100% certainty that it's not. My first test would be a syphilis IgG, but this is something that you just for fun. I'd still now seeing the left eye. That's really not in the differential for me. But if that was the only thing that I saw, that's the other item I'd have.
Sure.
So, you said these are deep lesions. Usually I think of
They're probably
punctate.
pre-retinal.
Yeah.
Yeah.
So I think there's two components.
It's hard to
So I
tell
think
from the
they're-
photo, but it's classically in sort of a syphilitic picture that you'd imagine them to be pre-retinal.
So I think there's actually two components, because you have the very focal ones, the very bright ones, and then if you look, there's actually deeper lesions kind of throughout, especially the suprarenasal area extending from the vessel and going kind of out. It looks like there's this big area of placoid retinitis that's probably deep.
Yeah.
And then the yellow, brighter lesions are probably superficial.
Yeah, I think there are multitudes, and this one looks actually a little atrophic here if you look at that as well. So multifocal retinitis, maybe pre-retinal lesions as well. So multifocal inflammatory lesions, that differential I think starts to get smaller, right? So certainly with syphilitic, but let's play the game Dan wants to play. So if I said you had a subretinal component, a pre-retinal component, and if you will, a deep choroidal component. What are the inflammatory diseases you're thinking of? That's what you're getting at, right, Dan?
Yep.
So I would say sarcoidosis is probably the one we all agree is the great masquerader. Anybody else have others that you would think of?
I mean, tuberculosis in the right patient setting.
Yeah.
And the other disease that can produce white spots in all levels, choroidal, subretinal, intraretinal, would be Bartonella, but you never have this many spots.
Interesting how many of those things are like masquerades that we talk about all the time. And you theoretically, I mean, it doesn't look like viral, but you could have viral that has multiple layers. It's not going to be pre-retinal. It's going to be an inflammatory component. All right, cool. So we already know the answer. Great. We've ruined this case because now we're done. But let's just run through. Oh, here's the other fundest photo, Dan, for you, just so you can see and smile and be happy. On seeing the actual, you can count the nerve fiber layers here. Here's the OCT. Yasha, you wanted the OCT before. What were you particularly looking for? Let's just say everything. What's your pathogenomic findings you're looking for
So
here?
infections highest in the differential layers of the retina are something that I love to look at. So if you're
Just in your spare time, layers in the retina are those things you like to look at.
mostly my spare time.
Yeah. Okay. Very good.
And I do.
But
love,
you are
this
married,
is one of
right?
My favorite
Life's a fellow.
conversations
She's
with
never
my
home.
residents and fellows. Like, is this a full thickness involvement? Is it a chorioretinal involvement, or is it a outer retinal involvement? So when you see that level of ellipsoid zone loss, that to me, of course, when you're looking at an optos photo, sometimes it's hard to make that distinction. But now that you're seeing the OCT, now I'm fully on board that this is a sort of a placoid syphilis because it involves the outer retina. We also know that from OCTA, there's choriocapillaris involvement as well, but you don't have that diffuse large enlargement of the choroidal space.
Absolutely. Yeah. Well said. Let's keep going. And the other thing I'd point out here is you can see some of the lesions here in the outer retina and even the right eye with the vitritis. And sometimes it looks like even the RPE can be thickened in these kind of cases. So something to look out for too. I always like to point out that the ELM here is intact. So maybe that means a good chance of visual recovery in this patient.
Can we actually talk about the Lyme testing? Because I see this all the time. For
Yeah,
patients.
we're going to. I'm going to talk about because I'm going to show you the labs here. Just a fundus autofluorescence, just again, another kind of pathognomonic, I won't say pathognomonic, another suspicious finding in syphilitic disease, these large hyper-autofluorescent plaques. Okay, so here is our differential just for everyone's knowledge. Obviously, I put stuck syphilis in the middle just for the heck of it. And here's the prior workup. And this is what we were dealing with, was not only that the Lyme was positive, but the ANA was positive. So, sir, go ahead. You wanted to criticize the Lyme. Go crazy.
So I see Lyme testing all the time for patients that are referred in. And personally, I've ordered Lyme once in 6 years, and it was for somebody who had the pathognomonic rash, had a target lesion, had been in a endemic area when they got right before they got the rash, and that is the only setting that you should be testing for Lyme in. But when we talk about Lyme uveitis, there was a survey that was sent out to all uveitis specialists around the country, and this was published a few years back, and I think one person claimed to have seen a case of Lyme uveitis, and claimed is the key point there. So I think that for some reason everyone thinks of Lyme in the workup of uveitis, and it's actually even in the BCSC in the workup of uveitis. But in practice, I don't order
really?
it. Yes,
It is.
it is.
So,
Well,
we're
we did
obviously in the Midwest, so many of us trained at institutions, like a lot of us trained in the Southeast. I practiced in the Southeast. We didn't see a lot of Lyme. You're in New York, maybe a little bit more Lyme than we get here in Ohio. Do you test for it?
I don't. I think it's sort of like the intern mantra. It's like only order or test if you know what you're going to do with it. And
Well said.
I think in this circumstance, you end up in a situation where you have low pretest probability. And if you end up having a false positive, it can throw you off the track.
Which Lyme has a ridiculously high false positive rate too. And it cross-reacts with multiple conditions, including syphilis.
Right. So,
people get thrown off.
So I think that is clearly the case here. So this patient is positive. VDRL LP is also positive. So I know our practice, and Karine, what's our practice here in Cleveland when you are positive for syphilis? Should people get an LP?
Yes, everyone should get an LP, and here we also treat for neurosyphilis with 2 weeks of IV penicillin.
So Yasha, what's the practice pattern in your community?
It's the same.
Great.
It's the same. The interesting thing
You were
is
taught well.
we used to. Do you guys admit them for 14 days, or do they go home
No, we
with a
do
PICC line?
not.
Yeah,
We
admit 'em
may
for
admit them for maybe 48 hours, make sure that they're responding nicely to the penicillin, not getting a horrible Hertzheimer reaction, and then they get a PICC. No, they go home with a PICC line.
Gotcha.
Yeah.
And just to play devil's advocate here, if you know that you're going to be treating them for neurosyphilis, then what's the advantage of doing the lumbar puncture?
It's a great question. It's actually something to follow patients with, because I'm going to show a case here in a second. These patients for a long time, for some, don't get penetration in the brain. So with the penicillin, so if they still have some neurosymptoms and you don't have your CSF VDRL and you don't know the titer, you can't really tell.
You see, my residents asked me the same question this week, and I was stumped because they said, remember the case that was retreated, no one checked the CSF again.
Yeah. And so,
why do we do it?
Because ID will and neuro will when they're symptomatic. So the reason why is some of it also is to prove that they do have neurosyphilis, and I do think there are people who advocate for LPing these patients once they're positive. And not too many people do that anymore.
But isn't by definition neurosyphilis when you have syphilis?
100% agree. Yeah, 100% agree. I think it's more to like, let's say they came back in 3 to 6 months and they still had neuro symptoms at that point, right? And if their CSF was positive again, would you be able to say, well, is it getting better because you had a titer, or is it not? I think part of that is just, it's kind of the reason why we all biopsy for sarcoidosis. It's not the right now decision. It's the decision that's coming 6 to 12 months down the line that you're not sure what kind of information you're going to need.
Do you want to comment on increasing RPR levels in the blood following treatment?
Yeah, please go ahead. You should comment.
You
No,
comment.
I want you to talk, please.
No, I think that if someone is having a recurrence of syphilis, we can check the serum and see that the levels of RPR are going up. And that is another way of treating for neurosyphilis again.
Absolutely. What I wanted to show is, let me ask you this, because, I think we see, and this is a bias that I think what we have, of a lot of post-treatment, these patients are still inflamed. So, Dan, how long, or would you, when you were practicing, you still see patients once in a while, I know. But, I will say Dan, obviously very well known, is a reformed uveitis specialist, as he likes to say. So, prednisone for these patients afterwards, Pred Forte for these patients. What's the incidence of a lot of post-treatment inflammation? Are you doing a lot of that, or were you doing a lot of that when you were seeing these patients a lot?
Well, I mean, we've all made the mistake of treating these with the steroids alone, and they get worse. So as long as you're covering them, if there's a really significant inflammatory response, I'll absolutely cover them with steroids.
Yeah. Sumit, what's your experience been? Do you have to treat them for a long time, a short period of time, or?
I think it depends on how long they had their ocular disease for, because I've seen it last for a long time.
So
after.
I'm going to show one of Sumit's cases here.
I think that I treat post-syphilis inflammation with prednisone alone, and that's at the recommendation of the ID people.
Yeah. So this is a case Sumit actually had of a patient who actually probably had syphilitic disease for 3 years, maybe 4 years untreated.
3 to 5 years.
3 to 5 years untreated for like cystoid macular edema. There's pre-penicillin, a month post-penicillin, even a year post-penicillin. Still has a fair amount of leakage out in the pre.
He had at least 3 years, maybe 5 years of CME that was being treated as just CME before the diagnosis of syphilis was made.
And Sumit, what was the treatments that you employed during this window of time?
So initially, this was before I saw him, so initially he was just being treated with topical drops for a while. Okay. And then at one point, I think he did get a course of oral prednisone, and that's when things blew up in the eye, and that's where the diagnosis of syphilis was actually made, because he developed the other signs other than CME. He developed vitreous cell, AC cell, lots of pigment, and that's when they got the workup. But before that, it was mostly topical drops to treat the CME, and it was just called idiopathic CME at that point.
So, we're going to move to another case, but there's just things to think about in some of these cases that I think can have them. I've dealt with this now for like several cases of post-syphilitic CME that you're dealing with for a long, long period of time. I haven't pulled the trigger on intravitreal steroids yet. It makes me still nervous, and I'm a gutsy person sometimes. Yeah. And this one I wouldn't.
I would make two comments. One on testing, because we often see testing done incorrectly, is to do the testing algorithm is not to get RPR first, because you can get false negatives there. So to make sure to get a non-treponemal, the treponemal test like a syphilis IgG first. And then reflex if that's positive to the RPR. And sometimes in HIV positive patients, you can actually get a false negative RPR from the prozone reaction, where they have to go back and redilute the RPR to look. And what you're looking for with treatment is a 4-fold reduction in the titer. And a doubling of the titer isn't enough, because of the way the RPR is done. It's very qualitative, even though they give us a number. It's a very qualitative test.
Excellent. Yeah, so the take-home points from this, obviously, syphilis test for everybody. Syphilis IgG, treponemal test first, non-treponemal confirmatory, follow the non-treponemal test. Treat all these patients as neurosyphilis, and watch for post-infectious inflammation. This is your patient, Sumit, 2 years. 2 years after penicillin is of difluprednate. That's how long it took to get rid of the CME. It's an impressive amount of treatment that you need. And I think you're right. It has to do with how long they were inflamed beforehand to
so
really
it's interesting, because right when we treated him, he asked me when things would get better, and I told him about half the time that you had it before treatment.
Yeah.
And that's about what it took. He had it for about 4 years, and it took about 2 years to get him finally under control.
So that's your rule of thumb, about half the time?
It's sometimes longer, sometimes shorter, but that's what I've seen when I've had to treat these long-standing inflammation cases post-infectious.
Great. Cool. Anything else? Dr. Martin, you get last word on syphilis.
Nope.
You are known as the syphilis expert on this panel, so
it's my favorite disease.
Favorite disease, syphilis. Dan Martin's favorite. All right, second case. Let me show our next case. No particular order. Let me show this patient. Another thing that a lot of us deal with, post-surgery inflammation. So this is a 77-year-old female. Several weeks after a cataract surgery, develops inflammation with vitreous haze. She was tap and injected, had Banks, FTAS, and DEX performed. She had no growth. She got back to 20/30. She proceeds to have cataract surgery in the right eye, which is actually, this story is actually quite surprising, because usually most people have the cataract surgery already booked back to back. So the fact that she was able to delay it until that her endophthalmitis got better is amazing. So she proceeds to have cataract surgery in the right eye, but several weeks later, so this is several weeks, she develops AC cell and vitreous haze, has a tap and inject performed in her right eye. So she presents for an evaluation of uveitis. I'm going to say 2200 right eye, 2+ cell, 2+ haze. Her retina is attached. Her review system is negative. I'm going to tell you uveitis workup is negative, including B27, ACE, chest x-ray, syphilis, TB. Everything is negative. So my first question for you is, patients who are post-surgery who develop inflammation. So this woman had an acute inflammatory episode in one eye, and then something that happened a couple of weeks after in the left eye. Should all these patients be worked up for uveitis? So is this like new uveitis that pops up in these patients that, in your experience, that you've seen, or is this something related more often to the surgery itself? So Yasha, what do you think?
I think if it was one eye and it happened, then certainly you have to think sort of an indolent or chronic endophthalmitis is probably highest on the differential. By the virtue that it happened in the other eye,
Yeah.
well, then all of a sudden, there's really 3 categories of diseases, right? You have essentially infection, you have inflammation, and then you have masqueraders, right? And in the circumstance of her being 77, you can rule out non-infectious uveitis as the presenting sign at 77 years of age. So that brings you really into infection and neoplastic. But given the fact that without even looking at any of the photos, my probably number 1 and 2 on this differential is going to be primary vitreoretinal lymphoma.
Okay.
And then because it happened in the other eye, but I certainly will still have a very, very high sort of suspicion for infectious etiologies. And it's not uncommon that you can have ARN turn into BARN. So I think a really good peripheral exam here would be valuable before essentially starting on oral prednisone.
Well, I'll tell you, I saw the patient, so a phenomenal peripheral exam was performed.
So African American?
Caucasian.
Okay. So I think in African Americans, you're much more likely to see post-surgery inflammation that can be very, very resistant and take a long time to go away. But this level of inflammation, I'd be a little less likely. And I am worried more about infectious here,
Okay,
too.
so infectious are possible masquerades like lymphoma is what I'm hearing.
I think that's a really good point, Sumit. Like Alan Palestine published that paper, and they basically said, well, what were the risk factors for chronic inflammation after cataract surgery? And we really don't, we don't talk about this enough, but race was one of them, and presumably that there's more pigment on the iris that gets released, and then also iris manipulators. But very rarely did those individuals have vitritis.
Mm-hmm.
So that's a really very unusual presentation of just sort of post-operative inflammation.
So Sumit's going to have a paper out soon that actually confirms this with some imaging. I won't spoil it. You'll have to wait for Sumit's paper. So vision recovers to 20/30 at 5 milligrams of prednisone. She calls with new vision change. So here is her anterior segment of her right eye. Another nice color fundus photo. Dan is smiling. He's non-optos photo. There is her slit lamp photo showing these kind of beautiful keratotic precipitates that you see. Here's an ultrasound confirming the vitritis here. So now that I show you this, what would you do at this point? I'm showing you this kind of picture. Corrine, what are you worried about?
I think you have to worry about an infection.
All right.
So you have to tap, culture, and inject.
So if this is infection, do you think it's possible she had bilateral infections? Do you think so? Yeah?
I'm
just asking, that's all. This is the second eye.
Has there been a cluster from this,
Really
whoever did the surgery?
No, this hasn't been. There's been no cluster.
By the way, how's the other eye doing at this point?
2025 at this point.
After the tap and
After the
inject,
tap and
no
inject,
recurrent
yeah.
inflammation.
No recurrent inflammation.
Yeah.
Clusters certainly happen, but they happen on the same day.
She had both eyes done at the same day. You would be concerned about a cluster.
Right.
She didn't have that done. All right, so let me show you what we went through here. So tap and injected, added antifungals this time because maybe it's a fungal. Maybe this patient had a systemic infection, right? Maybe it's actually true endophthalmitis from something else that was going on. Held for anaerobes and a rare fungus. No growth. Restarted prednisone, and now improves. And now upon a taper of prednisone, now looks like this again. So you have 4+ cell in the eye. I think the eye is screaming at us that, what are we doing? Yeah, sir, go ahead.
So the past medical history was?
Really not contributory.
Is she in pain?
She's not in pain.
And she had no GI?
No GI, nothing GI or GU.
GU, yeah, you know where I'm going, right?
Yeah, so where are you going with this?
So the association of any manipulation of the GI-GU tract with candidemia that can result in occult seeding of the vitreous that can take many months before it becomes obvious that this is an endogenous fungal endophthalmitis.
Does she dilate well?
So I was about to ask you, Sumit, what's your clue here that for you that something funky is going on?
She's not dilating well. If that's a dilated photo, then there's probably something going on with the lens. You got to take her to the OR, I think, and explore.
And just to finish what I was saying a minute ago, even the simplest things is the case reports of people passing a stone.
Yeah.
That's sort of a GU mobilization of fungemia, bacteremia. But no stones, right?
Yeah, no stones. But fair. I mean, I think at this point we don't know for sure. So blood culture is not unreasonable to do in this patient as well. But I think Sumit's getting to it. There's suspicions here that there's an infection. Corrine, you would tell us we should take this patient to the OR 10 minutes ago, right?
I think you should take the patient.
Okay, fantastic. All right, so let's talk about the practical side of taking this patient to the operating room. So we have, 3.5 vitreoretinal surgeons. Actually, Corinne does more vitreoretinal surgery than Dan. So 4.5 vitreoretinal surgeons. Al, you like that one? That was good.
That was good. I got it.
That was good.
That was actually very good. I'll give you that
Appreciate
one.
that. Thank you. I've been working on that all night. Tell me, how do you approach this? All right, so it could be in the vitreous. It could be in the lens. I got an eye that doesn't dilate. So we're going to have hopefully some fellows watching this. What's the approach? How would you approach this? So Yasha, how would you approach this kind of case? I'm going to tell you, it's 25 gauge, but tell me what you're doing for the front part of the eye. Are you manipulating the lens at all? What are you doing? Are you taking the lens out? What are your thoughts?
So I think that's a great point. So let's go and say the presumptive diagnosis is chronic exogenous endophthalmitis right now. So if that's the operating assumption we have here, then I think at this point, when you have this level of like anterior chamber inflammation, it becomes very hard to get a real sort of sample. So I would probably do an AC washout at this point in time, and then I like to do the vitrectomy, the dry component under air. So I'm actually starting the vitrectomy under like air, so that it basically maintains the pressure in the eye, so that way I can take a sample, and I have a 3 cc syringe with one of my assistants pulling back on it, and then I can send that for both bacterial fungal cultures. It's important to let them know, especially if you're worried about sort of P. acnes, and I'm also taking this kind of right by the IOL. I'd like to try and take it as close to it. So that means that my visualization has to be better.
Yeah.
So, and I'm asking my microbiologist to kind of hold this for about 2 weeks.
Yeah.
So that's an interesting point, because I used to do the whole undiluted and diluted samples, and then I talked to the lab and they said, oh, we just combine them and spin them down. Yeah, so I've stopped doing that.
Yeah.
I don't do that anymore, because the lab, literally, the micro lab said, oh yeah, you send us 3 samples, we combined them into one and we spun them down, and we take the spun down pellet and use that.
Yeah,
so I don't even bother with that anymore, because I think it puts you at a little bit higher risk doing all of that doing the undiluted sample.
So even for my lymphoma samples, I have now, because we are cytology based. So every institution is different how they make the diagnosis. So we are a cytology based place. We don't make our diagnosis based on flow. Flow is confirmatory. But our pathologists are very, very comfortable making the diagnosis of lymphoma based on cytology. So I do semi-diluted samples just to make sure I get pure vitreous. Like I'm trying to get as much of the vitreous in, but I'll reform the eye very quickly because I've had choroidals occur. And even in the air scenario, I find my view gets very challenging at times. And I know people have argued for fluoron. And it's really, just have a really good pathologist. If you have a really good pathologist, they're doing the vast majority of the work here.
But they spin it down. Pathology absolutely spins it down. They don't look at the separate
You're
samples.
The same, just basically you're on fluid.
For if I
you're
am
not
doing
if
I'm doing for an infection, I am on fluid.
You're on fluid.
I'm on fluid.
And if lymphoma, same.
So in lymphoma, I do what I call semi-diluted. So I'll form the eye, I'll clamp, do my first, take my sample, and then reform the eye, stop, so I can get a better first sample. It's that first sample that I'm sending for cytology. So then I'll clamp again and then stain the vitreous, because I know where I need to go. I can see the vitreous and I can see the cells. So I make sure I go after those things. And then I do a fully diluted sample for my flow cytometry. Yeah. I've switched, I'll show you later. Maybe we'll show in this thing some bad stuff.
Don't you want to really look at the capsular bag
Yes,
here?
so that's what I wanted to get to here. Is
So I'm doing hooks, or I'm at least manipulating the iris enough to get a great look at the bag. And then if I see anything, I'm going to consider taking the lens out.
So that's what. So your inflection point is what you see on the lens.
Yep.
Right. Okay, I agree. And that's, I think, what you'll see here and what we do here. So here's the surgical video. It's probably going to work this time. Woo! All right, it's a little longer, but you can see it's a little older because it's non-valved. Anyway, so here you can see how poorly dilated this eye is, right? And now we put iris hooks in, and now you'll see the manipulation here. And you can see here in a second what's going to come up right there. There it is, that yellowish stuff right on the lens, right in the haptic. It's pretty amazing. That's what it is as I'm explaining. Look how sticky that stuff is. Wow. That was not me blowing my nose on there. I was wearing a mask even in that day. All right, Dan, I show you that. What's your guess on the bug?
Staph epi.
Staph epi. What's your bug guess? We're just playing this game.
You only got 2 options if it's in the bacterial spectrum. You have P. acnes, Staph epi, and then unlikely to be Candida.
All right, so you're going with?
I'm going to go with P. acnes just to
P. acnes to be different, sir?
I mean, usually it's P. acnes or now C. acnes because they changed the name. But this is going to be weird because I haven't seen those type of KPs show up with P. acnes before.
All right, and the person who always knows the correct answer, Korean Louder, what is it?
Staph.
And as I said, Korean louder always knows the correct answer. Staph epi is right. So, but it's interesting. And Dan Martin. But look at this. My cultures
Who
were
was that
negative.
guy who wasn't doing much surgery these days?
You're good. You are, because everybody else do the surgery. It was the surgical procedure that was done correctly. Thank you. You'd still be in that eye if you were operating, man. Anyway, so what's interesting, the cultures were negative, right? But the PCR was positive. So this is another thing we've done is we start holding these things for PCR or send them at the same time on some of these unusual ones. We want to have the ability to do PCR on this.
Doing it on all cases, and then what specific? Is it just universal PCR?
Yeah. So go
So
ahead.
I asked the lab to hold for 30 days in the -80. And if nothing comes back from culture in the first 21 days, I have them then send it out because there's a high out-of-pocket cost for PCR for the patient. Insurance doesn't cover it. So we only send it if all the other testing comes back negative.
Yeah.
And so in the order, I literally have written in, say, hold at -80 until, and I put a date for 30 days. And they can throw it out after that. But until then, I tell them to hold it. And that saves cost to the patient if you get testing from something else. But it's about $1,000 out of pocket if you send it.
So we now have it internally here in the clinic. So the price has gone down. We do have
Right.
like a bacterial PCR profile. If you're doing fungal PCR, it's still being a send out. So we have it internal, but it's still pretty expensive. The primers are expensive. That's for
So
the
what if
case.
let's take the hypothetical. I know we're all sort of academic, but what if you were in the private sector?
Yeah.
What if you were only operating at ASC?
Yeah.
Is this a case you'd actually try and actively do in the hospital so that you have access to cultures, or do you think that the Wills Group published a really interesting paper on a post-injection endophthalmitis, very different from this.
Right.
But what they really came to their conclusion was that while it may prognosticate visual outcomes, it didn't actually alter their decision making.
Sure.
So in this circumstance, say you're in the private sector, would you just go and take out the lens, inject intravitreal vanc, ceftaz, plus minus ampho, and then be done? Would that be the strategy?
I'd send for culture for sure.
Well,
even
no,
in the
his-
ASC.
yeah.
But you're talking about PCR or are you talking about culture? So even in an ASC, you can order cultures and they'll get sent out and they'll be done. You don't have to do them at the ASC. You're not going to. You're going to send them to have. You're going to have some lab that you work with, no matter what.
Yeah, I think your point of is it being sent to the right place if you're in an ASC
Right.
and such. I think these are ones where I always defer to the person who's doing them and say like, tell me where you're gonna. Your community. Like when you send something off, is it hanging on the outside door waiting for LabCorp to come pick up, and the guy doesn't show up and it sits there for 3 days? That's one aspect you want to avoid. Or is it something that's actually you have a regular pickup, it's being processed relatively quickly? And so these that if they're not processed quickly, I'd be concerned. I'd say do it in a hospital or do it somewhere the sample is going to get there, or send it to the person who does this. And we say it all the time. We're not Sumit is. Sumit's a phenomenal surgeon. I'm just a monkey. You don't need to be incredibly, you just have to have the resources around it, and that's really, really important here.
So you left the lens in.
No, I took the lens out.
You took the lens
Yeah,
out.
I took the lens out, and then did a secondary lens 3 months later. Yeah.
That's what I was going to ask.
Yeah.
So
No.
actually, what do you think was going on in the first eye?
I think she had staph epi. I really do. I think she had it because it's probably on her
It's like
lids.
the worst luck ever.
Yeah, I think she had to have had it because she got better after the tap and inject. I think she had staph epi. This one I think was a little more indolent, so it got into the bag, and you can see I think once it's in that haptic. How do you you can't
You're not
sterilize
gonna
that?
sterilize that until
You're not
you
going to
got
get
the whole
that.
bag.
People have told me, you open the posterior capsule and injected the antibiotics. Like no, biofilm. It's going to just sit on there, and you just got to take this thing out.
Independent odds, that's 1 in 400,000.
I know.
That's
She put a
like-
lottery. She's 2030. She was 2030, 2025, 2030 for years after this. She passed away. This was a couple of years ago. She passed away. And her daughter is my patient too, and just comes in and says, "Thank you for taking care of her. She did so great." It's so crazy when these things, like this was a wild one. And the patients feel bad. They're like, "What did I do wrong?" I'm like, "You did nothing wrong. This is not you." Just bad luck sometimes in some of these patients.
So say, just for, I think I know the answer for all of you, but I would just want to pose this hypothetical. What if you have a patient who is really insistent on they want sort of visual rehabilitation quickly?
Yeah.
Would you do a secondary IOL at the time of that removal and the capsulectomy removal?
But we've debated this a lot, so I'd love to hear everyone's opinion. And I know Karine doesn't operate, but I know Karine has an opinion on this as well. So we're gonna all answer. Go ahead, sir.
So it's a scary idea.
Yeah.
You have an eye that you suspect's P. acne staph epi or some weird. I had a couple of cases with the mycobacterium. And the idea of just taking the capsule and put another IOL in is kind of scary. But I've done it. I've actually never had a problem with it. I would probably have done the same thing here. Just the conservative thing is just to come back at a later date. But I have put one in but if you're putting one in at the time of the acute surgery, you're putting in an ACIOL, because to clean that thing out, you got to take the capsule.
Okay. Zoom it.
I've done it too. I think if you have a presumptive diagnosis because you've done an AC tap and it's grown for P. acnes, and in those cases I feel much more comfortable, and I won't necessarily do an ACIOL, and I'll take the bag and everything and do a scleral suture like an acreose. And I have not had recurrent infections, but I have seen recurrent inflammation in the post-op period. But if I don't know the bug, I tend to be a little bit more cautious, because we've had a couple very strange ones where it did recur, and we want to be really careful because of that.
I would definitely wait.
Yeah. I would tell you, having taken care of enough wacky bugs, if you don't know what it is, don't do it. So if you know if it's...
I agree with that.
If you know if it's C. acnes, P. acnes, I think that's different. And those are the ones I will put in an IOL at the time. But if I don't know, if it's fungus, forget about it. Put a lens in, that lens is going to get like essentially redone. And even in an acreose case, I'm still concerned.
Yep.
You know, I'm still concerned that cortex suture is a nidus for something. So I tend to be a little more conservative in this and wait. If I know for sure it's P. acnes, that's one thing. If I don't know it's P. acnes, if it's not P. acnes or staph epi, I wouldn't do it.
Yeah, and the one recurrence I've had is actually a lady who had P. acnes. We took out her lens, left her aphakic. Months later, after she was doing great, came back, put in an ACIOL in. 4 years or 5 years later, she had recurrence of the P. acnes because it was growing in between the ciliary processes, and we had to go in and laser the ciliary processes in order to get it to not recur.
Yeah, those are, and we shared multiple of these cases of just wild bugs, good vision, recurrent inflammation. And you look in their eye and there's nothing. You take the lens and all of a sudden there's like these little spots on the ciliary body. So these things are really, really hardy, you know, and can take a while to take care of. Next case. I always forget. Oh, okay. Now I know what this one is. Okay, excellent. So
this is your ICD-10.
Yeah, this is my ICD. This is there's an ICD-10 code for this one. 58-year-old female, vision loss after being attacked by a cow. She owns a farm. She was taking care of the cow. The cow, for some reason, actually rammed into her. Completely surprised, usually not a violent cow. Hospitalized in the ICU. She developed blurry vision, but she wasn't seen. About a month later, she develops pain. She was told she had Punctures, had a laser for blood in the eye, and 2 months later develops pain uveitis and had a periocular steroid injection performed with worsening. 2200 in the left eye. She's got 4+ cell in the AC of the left eye, 3+ haze. I'm sorry, I don't know why I put all that 4+ AC cell and 3+ vitreous cell. I can read my own notes. Here's my view in the left eye. Okay, so you can see a fair amount of vitritis. Really no other view that I can see in this eye. So here's the B scan that's showing that appearance. So what are your thoughts? I mean, she was in the hospital. Could this be Punctures that she had because she was pretty sick in the ICU? She was given periocular steroids. Could this be an infection? You know, what are your thoughts at this point? What's the kind of right thing to do at this point? Joshua, what do you think?
I mean, you have to rule out the most severe entity, right? Yeah. So I think you have to sort of assume that there's always the possibility of it being an infection, especially if you can't see well enough to the posterior segment. So that has to be number one on your priority, and then you can always come back to a non-infectious etiology later.
Okay. Corinne's smiling. What do you think, Corinne?
No, I'm just thinking, how could someone give periocular steroids to this woman?
Yeah. Exactly. So I think we all agree, maybe not the best thing to do.
And by the way, do you have the video of the cow attack?
I do not have the video of the cow attack. Oh, it's terrible. Right. I know, but it's awful. She felt horrible. So I tap and inject her. She's in my office at this point. I think we all would have done the same thing. Do some labs as well. Vanc, Ceftaz, Ampho. I think thinking the same thing. Get her hospital records as well. Looking for any signs that she had like an indwelling catheter for a long time. You know, or anything, maybe she was infected. And so her toxo IgG is positive. Her IgM is negative. All of her serologies are negative. Her cultures are negative. I look through everything and no history of any infections in the hospital. So now I'm going to tell you she's toxo IgG positive. She gets worse after a periocular steroid injection. I have all my cultures are negative. She kind of looks the same after I tap and inject her. I didn't give her any clindamycin, or I haven't treated her for toxo. Well, how would you all approach this? So this is now our next level of information. What's the right thing at this point? Do you treat them for toxoplasmosis? I mean, she's staying the same. She's 2,200, still got a fair amount of cells. She's not any worse. What would you guys do at this point? Colleagues. Dr. Martin, what are you thinking?
So the toxo IgG is always confirmatory, not specifically diagnostic in the absence of anything that looks like toxo. I don't see anything that looks like toxo.
Correct. But the vitritis is pretty significant.
Yeah,
I mean,
so maybe you're missing something. So could it still be toxo that I just can't see? Yeah, I guess so. There are lots of people walking around who are toxo positive.
Okay.
May have nothing to do with their presentation.
Gotcha.
But I just file it away. It's still a possibility. Could wind up being that, but I don't see anything you've already given her steroids and she got worse? Or?
I didn't give her any steroids yet. I didn't give her any steroids. She got a periocular steroids before she came and saw me and got worse.
Yeah, you could, the flip side of this is what's the downside of treating her for toxo? You could
Okay.
give her Vitrectomy, or you could treat her with an oral, with Bactrim. Alternatively, you could also, you could take her to the OR, do a vitrectomy,
Okay.
Clean her out, and maybe get a better idea of what was going on and a better view.
Okay. So you just give me all the possibilities. I like it. That's good. What would you do at this point?
I would suggest a diagnostic vitrectomy.
So Corinne's doing diagnostic vitrectomy.
See, Corinne is just so much more smarter and definitive than I am.
I guess what's the time
So I would do what
course?
Corinne tells me to do.
What is the time?
Like
that's
So-
you
the
just
question.
gave the
So this is now 2
antibiotics.
weeks after
this is 2 weeks.
This is 2 weeks. I got all the information's come back to me. So I gave her the tap and inject. I probably had her come back in a week. So this is a week after I give her the tap and inject.
Okay.
No, nothing. Maybe 2 weeks. I can't give you. I don't remember.
Does she have pain?
She doesn't have any pain. What she's describing is loss of vision. She's not in any pain, even with that much cell.
And then if we're doing a diagnostic vitrectomy, then sort of Sumit, what's your sort of thought process on like what you're getting in the diagnostic vitrectomy?
I mean, so if you're doing a diagnostic, you're looking for infection, you're looking for fungal, you're going to send it for toxoplasmosis PCR at that point, and it's going to be therapeutic for her in a way as well because you're going to clean out a lot of that vitritis.
Yes.
The other side, the flip side of it is you could actually treat her with oral Bactrim and also prednisone and see what happens. What I'm very curious about is what happened with the periocular in terms of exam, because she thinks she got worse, but that doesn't necessarily mean that
100%.
she actually was getting worse.
So here's how I'll give you my thought process. When someone says they see purchers, did they see purchers or did they see retinal whitening?
Right.
If you saw retinal whitening and then you got a periocular and it was toxo, maybe this is toxo. So I don't know, but I'm trying
Yeah,
to.
but then your retinal whitening would be much worse.
100%. I would expect the
And I
retinitis to be a
don't see
ton
that.
worse, and it should be. She was in the hospital. This should be like fungus that makes sense, or bacteria for that matter. So I started Clinda, and I said, okay, I'm going to do Clinda, and if you don't get better, I'm going to only give you a short window. My OR is on Tuesday, and or like next Tuesday, and I'm going to see you. Let's see how things go. So she doesn't improve after a few days, and we decide to take her to the surgery. So here is.
Hold on. So
Yep.
realistically, do you think she could have improved that fast?
What I was looking for was, yes, I do think she could have improved because with the prednisone, she should have cleared some.
Right.
So I would have gotten improvement of the vitritis for sure, at least in this scenario. And you could make
I
an
bring that
argument
up-
for giving it 2 weeks, but I still don't know. I'm very uncomfortable prednisone only, not watching these patients. So I watch these patients like a hawk. Corinne and I agree on this, like every 2 day kind of looking at a patient, even if it's just to make myself feel better. I don't know if it's going to clinically make a difference, but at least I'm, I don't want them coming, losing it. And
didn't miss
even in the
something.
COVID times when we were doing this and we had patients like this, we're like, you're coming back.
You did, yeah. The point is, you didn't miss anything. At least everything's sort of covered.
Yeah.
And I agree with you. They could have improved, but the real reason I asked the question was not so much specific to this case. I think we see it all the time where people start some sort of therapeutic, and then they incorrectly conclude too fast that it didn't work because they never gave it enough time.
That's a good point because clindamycin for toxo is not going to work immediately. It's
That's
going to
right.
take a couple of weeks. 100% agree with that. But the prednisone on top of it should at least improve the
Should
vitritis.
have gotten better.
So that's what I was looking for. Improvement in vitritis so that I could see in more. And in the worst case scenario, vitritis doesn't improve and I'm wrong and it's still toxo. clearing it out. I'll see it. I'll feel better. I'll sleep better. And really, this is about me sleeping. And ultimately,
it is all about you, Dr. Stevens.
I just feeling better about this.
part of
What are you gonna say, Yasha?
Is there no view? Like, can you see like anything? Any
The
core
Optos was
retinal
Optos was the best view, and it had a hazy view. I mean, Optos is pretty good for that, but I had like nothing. I couldn't see.
I mean, just our history brings up weird stuff.
Yes.
you
No.
know?
So everything
Like,
about this is weird. I am walking in saying I don't know, but you know within 2 seconds of doing the vitrectomy, because like as soon as you see the vitrectomy, I saw fungus balls. Like you can see it. Like it's flying. I was like, how did I not see that in clinic? But it wasn't there. So here it comes, and here we go. We're gonna do the vitrectomy here. Sorry, the video is only okay, but my fellow at this point says, "Oh, look, there's this fibrous stuff on the surface of the retina. Let's go get it." I said, "Please stop. Please stop. Just don't touch it anymore." So it turns out this is culture's negative, cytology negative, universal PCR again comes to the rescue.
Yeah.
I get paid nothing by the universal PCR
so culture's
people.
negative because you gave her info.
Yeah, that's probably true.
So that's why the cultures
absolutely.
are
Yeah,
negative.
you're right.
So you're
Yeah.
just getting the PCR because you've already sterilized the eye, and so it's
Yeah.
a therapeutic vitrectomy
Right,
and
absolutely.
diagnostic
Yeah.
for you.
And that's fair. That's a good point. I forgot to mention that.
Because it would have taken months, if not years, to clear this
Yes.
if you hadn't actually taken her to the OR for the vitrectomy.
So I feel good. So she's done actually great. She actually developed a pretty significant pucker on the surface. So I actually, curious, I'm going to ask you a question, but I always want to put in elderly patients with uveitis, medications, infection, systemic immune suppression. Always think of these things that may be occurring in these patients and take a good history. So how do you remove plaques in fungal enteroophthalmitis? I've had a run of these of just like these sticky epiretinal membranes or remnants of the pre-retinal lesion. So Dan's shaking his head. He's going to tell me how satisfying it is to take it off. But tell me, I know there are probably a couple of retina people who are listening. Is this the easiest pucker that you ever do?
No, because you can't grab it.
Yeah.
Basically, it's pretty stuck, and your forceps just sort of go right through it.
Yeah.
And so aspirating it the way you were doing is a nice way to do it. You can do it. You can sort of scrape it, move it with a finesse loop. There's a number of different ways, but I will defer to you all.
Yeah. So this is now after.
And there's the other piece I
Yeah.
will say in infectious disease, in infectious causes, don't go after every little sticky stuff on the surface of the retina, because boy, you can do bad stuff, and a lot of that stuff's going to go away anyway with steroids.
And some of it sometimes is retina that was normal and just looks boggy. And you
That's
don't know.
Oftentimes,
That's right.
if you can do it, just peeling ILM over the fovea and then bringing it up to that lesion is sometimes safer if it's really sticky,
Yeah.
because I've seen it pull and cause a break in the retina right there.
Yeah, these are challenging. I'm going to show you one that I had. This is one of our fellows. This is
a different case.
This is
right?
a different case.
And this is where you can sort of see where the fungus came into the eye.
Right. This
Yeah.
is on the fovea. So I'm going to show you.
Yeah.
This is after I've treated them. They're inactive. I just want to show you this. So this is, again, we're clearing around it. This thing is sitting on the fovea. Here's the OCT, intraoperative OCT, just to prove to you, I'm not making this up. And so I want to show you how we try. We're like, okay, how do you get this? Because you can't grab it. As you said, Dan, it's like, how do you grab this thing? So the fellow tries a couple of different times, and like it's super sticky, and you can see it's bleeding a little bit, and he keeps eating into it, so it bleeds more. So I just walked in, and I was like, just bluntly dissect it. You just took it off and just let the whole thing, dissect, because the principles as both Suman and Dan, I think Yash was getting to, it's stuck, but if you find a layer and you can gently dissect it off, it comes. So this one came off, fovea is flat. Of course, she's like 2015 at this point, so she sees great. It's no, I'm kidding. Sorry, I was waiting to see if I could get away with that one.
She's your postdoc.
Brisk
That's what I would expect.
2030. We're gonna go with that. Brisk 2030. Okay, cool. Good, excellent job.
Was that Candida?
That was Candida as well. That was Candida in a setting of cancer, in a cancer patient who had. But she did really, really well, actually. We actually restored most of her vision. She was actually ended up like 24/40, actually. So it's not bad.
Did the patient with the cow have Candida from
She-
indwelling catheter? Or
I
something?
think so. It must have been. But I blood cultured her. I sent off for all these cultures, and nothing came back positive. And so it was only her eye. That's it. I
They
put her
can
on
get, like, a
antifungals.
transient fungemia. It's so strange with the GU instrumentation or an indwelling catheter, where they have like a fever for a day and then no other symptom,
Yeah.
and end up with fungemia in the
So
eye.
I talked this over. I'll talk about like how long you should treat these. If it's just the eye only, how long do you treat them with systemic antifungals? I'd still tend to treat them for at least 6 weeks, sometimes up to 3 months, just because you don't know where else it is. You were going to say something, sir.
I was going to say, do you have an OCT of this specific patient beforehand?
Of this patient before she developed it?
No, before she developed it.
When she walked in, this thing was on the surface of the retina.
okay.
Yeah, so my OCT is exactly that.
The reason why I bring that up is because, there's a debate as to how fungus gets into the eye. Does it come through the choroid? Does it come through the retinal circulation? Everybody on the Northeast thinks it comes through the choroidal circulation. But the thing is that actually Francesco Picci published a paper showing that it can come through both.
Yes.
And I would think that would heavily influence your surgical approach here, because ultimately you know where it's stuck, you know where it's coming through, because you have a full thickness involvement if it's coming through the choroid, as opposed to if it's coming through the retinal circulation. I would imagine your surgical approach would be a bit different.
So this is where I will say that, and I'll go back to this case. I thought we were done with it, but let's talk about it a little more, because I think it's actually quite good, is looking at the intraoperative OCT here. I think it actually helps you a little bit, because you can kind of make out where the layer was. I can make out that there was retina still underneath there.
It seems like this is coming from the retinal circulation.
I think it was coming from the retinal surface. And I've seen the ones that have come through the choroid. It's atrophic around it. And you can tell.
Is this coming from the nerve head? So you have that little band.
Oh, yeah. No, this thing extends over the nerve.
I think this came from the nerve. So look at it again.
Maybe.
Look at it again. Look at your video. Go back and hit play at the very beginning.
This course, by the way, online is going to be 14 hours. This is going to be awesome. This is going to be a fantastic course.
So do you see that fibrous band going back to the nerve?
Yeah.
I bet you that's the source.
No, I think the source is right. Well, it could be. I'm not going to say it's yes. So I think that's an ERM or like a persistent hyaloid that happens. I don't know. It could be, Sumit. I don't know for sure. I'm sorry, we're going to watch it again, because it was pretty slick when I did it.
Look at that. It extends right to
No, I know. I hear you.
And there was a full PVD minus this at...
Yes, I was able to separate.
And if it was coming from the retina in any way, it would have been much more adherent than that. I don't know. I think it came from the nerve.
All right, he thinks it comes from the nerve. There you go. That's it. I don't know. I mean, I think it's a fair question.
I mean, it's got to come from the vasculature somewhere, right?
Yeah, absolutely.
So it's either a retinal vessel, choroidal vessel, or a vessel from the nerve.
Yeah. No, I agree.
The way it's attached to the disc.
She didn't get back 20/40 if it arose somewhere primarily in the macula.
2025. All right. You can see the theme of all my Yasha, I think you're going to get the next one. All right. 79-year-old female. I think we have a thing for the patients over 60. I think everybody's been over 60. 79-year-old female. Oh, except
I've got one.
The first one. Okay. 79-year-old female presents for second opinion uveitis. Inflammation and elevated pressure started a year ago. Seen several doctors. I believe this patient sees Dr. Martin here. This is, I think, Dr. Martin's patient. Diagnosed with acute retinal necrosis, treated with Vitrectomy, but has inactive retinitis, but now persistent inflammation. She's status post 2 perioculars around both eyes ×2. She in the past has T-cell lymphoma, which is in remission now for years. She has a history of breast cancer. She's on Vitrectomy 500 milligrams a day. We don't know if she has any history of any sort of kidney issues, so I can't tell you why the dose is only 500. She's 20/40 in the right, count fingers in the left, 2+ cell in the right, and as far as the vitreous, pore dilation in the left. So here is our picture in the right. All right, and I'm going to show you the picture in the left. I can't remember, Dan, if this is your case or not, but I probably took care of it anyway. So what do you see?
You took care of it correctly.
It's a team approach. Right? The lovely thing here is
it's a team approach.
It's a team approach. It's uveitis. It's a team sport. Okay. Retinal disease is a team sport as well. Actually, ophthalmology is a team sport. So, Yasha, what do you see? What kind of strikes you here?
You are like the infection master today. Like,
I just figured it would be fun today to do some infection.
You clearly have large swaths of retinitis, and the other beauty of this case is you have ocular hypertension. I love the differential diagnosis of posterior segment involvement with ocular hypertensive uveitis, right? Because it's really just, for the most part, toxo, ARN, and like herpetic viruses, and I would throw CMV into that category.
Now, there's some who would say to you that CMV actually causes hypotony, and I would say to you, I've seen it both ways, but some people would say classically hypotony would be it. But I think Dan is the CMV man and will tell you he's seen it low pressure, high pressure, all pressures.
The other thing is, do we know where is she still in remission? Do we have like a updated history on that?
I'm telling you, as it came in, walked in the door, this is what we're given as T-cell remission, and we got to obviously search this out a little.
Both T-cell lymphoma and breast cancer?
Yes.
Wow.
Yeah.
Poor thing.
So I mean, it has to be an AC tap, and I would do essentially just given her age, probably the prioritization structure would be VZV, HSV. We don't have like the same joy as you. We send off like 40 micron samples for each test. So VZV, HSV 1, HSV 2, CMV. And then if I can get a little bit, I would try to send for Toxo as well.
Okay. So it's been going on for a year.
Yeah, it's very unlikely to be viral because it's too long.
This has been going on for
Yes,
a year.
1 year, and she got 2 periodicals. If it was going to be viral, which it probably is, which viral? If it's 1 year of
CMV.
therapy.
CMV.
So
right.
CMV, I was going to point out, go back to the right.
Yeah, sure.
Right eye's active.
So the right eye is inactive, right? We're not concerned about this one? Or
I think the right eye is active.
Well,
I think
it's
this is.
active.
I think that thing is active.
I think this is
Yeah.
whitening.
Yeah.
I think this is probably
Amazing.
whitening. Yeah.
So the point I was going to make was it's really hard to call activity on the basis of Opto's photographs
Sure,
because
yeah.
of color.
Yeah.
And if you'll look at that area that is just inferior, so you have the area at 3:30 o'clock, that guy right there.
Yeah.
So you see that it's atrophic, like if hitting posteriorly. You have a ring of atrophy. In the middle of that, you kind of have this sort of consolidated white area.
Yeah.
So that is, I just want to point out to everyone, that is not active. So that is classically what CMV. When it becomes inactive, you'll wind up with some persistent areas of whitening within the scar. But if it's within the scar, it doesn't count.
Okay, let me ask you
can
this:
see
if
that
it was
But
Toxo,
the area,
You
but
can
the
see
area,
that in
but
Toxo.
exactly. But the area that is peripheral to that, that could be active.
Gotcha.
I just can't tell on the basis of my. I love the Optos photographs because of the geography
does
that
that-
shows me. But I just haven't. You cannot. It's very hard to call active or inactive.
sure, based on the thought.
Does that area of the fibrosis then, does that go away, the area inside the scar?
Actually, not. Usually that stays just like that for a long
So
time.
in CMV, I think this is really well known. I think Dan published a couple papers on this on like the photograph from the good old CMV articles days. But in Toxo, I think this is where it gets challenging. Is that I think sometimes in Toxo this can be active,
It could be.
Yeah.
If,
And
if
then
it's
it goes
toxic.
away with treatment.
and it goes away with treatment. Absolutely.
Yeah, the stuff peripheral looks.
Yeah,
a
it's
little
pretty
more
cool. Again, you're
suspicious.
right. It's a cool case, and we have cool infections. And then you look at this, and this is broad retinitis. So broad retinitis has been going on for a year.
Toxoplasmosis.
But this is the first time we've seen her, or
This is the first time I'm seeing her. Yeah, no.
But how do you? So we're going by our history in terms of it being going on.
Don't you
for-
listen to what people say when they walk in and they say, "Hey, this has been going on for a year, sir"? No,
Well,
We were
not
so-
like no. I actually sometimes I don't.
I don't want you to talk, madam. I will figure it out on my own.
No history, that's too easy.
You know, disease that is this chronic and this extensive in the periphery. So if Toxo can do that, it
Yeah.
takes a long time for it to get like this. Doesn't look like the typical Toxo that you'll see, but an immunosuppressed patient, I got lots and lots of photographs that
And
look
she
like
got a
this.
PST.
2 periocular steroids as
Right.
well.
So the other thing
She's
is
locally immunosuppressed, and her chemotherapy was,
Years ago, as far as we can tell, and I don't
but
know
for
what it
her
was.
T-cell lymphoma, so some of the times the stuff they use just torches T-cells
Sure.
permanently.
Absolutely.
So she may have a CD4 count of,
-6.
yeah. So
What were you gonna say?
that was the same point I was going to make is with the prior chemotherapy, you can see
Yeah.
this major immune regression, and then it can actually be okay for a while, and then it kind of bounce back and forth.
And she's also in her 70s, and her immune system is a little bit different. So, all right, thanks for your thoughts. This is my differential, and I think the top 2 are what I'm thinking about. And if I had to bet, I'm going to bet Toxo just based on this.
Yeah.
AC tap, and I inject them and get labs. Her Toxo PCR is very, very positive in this.
You got it from the AC?
I did get it from the AC. We had a dry vitreous tap, but I treated with clindamycin. Here's like that. So the question of what activity looks like. Look at her 2 weeks later. I mean, just a week later, already having improvement in this lesion. I mean, like that one is pretty white, that central area, and this lesion is consolidating with its color.
But look at the little isthmus of that in that
Yes.
area of atrophy.
Yes, it hasn't.
See how that hasn't changed?
Yeah.
That's typical.
Yeah, and
Doesn't change.
but also interesting. See the whitening here that started, and that has
that
improved.
could-
Yeah,
yeah.
it's pretty cool. And then the other eye, I can hallucinate it's the same. I can't tell you it's any better. That one's going to take a while to kind of treat. So I wanted to show.
Did you give intravitreal Clinda to the left eye?
Yes, we did intravitreal Clinda in both eyes.
How often do you repeat it? If it
Yeah,
looks
it's a good
like that?
question. Can we get to that? Let me show this one, and
Okay.
then we'll talk about that together, because I just wanted to kind of talk about treatment, maybe all in kind of one fail swoop. But this is a patient who has known toxo, who comes for an opinion of her left eye. She was started on azathioprine because she has a sulfa allergy. She's on topical and oral steroids with minimal improvements. She had 2 injections as well, and supposedly had some fluid removed. Now she has elevated IOP as well. So she's allergic to sulfa. Her toxo IgG has been positive. She's on pred. She's on azithromycin. Hand motion in the left eye. 3+ cell, 3+ vitreous, and she has a total retinal detachment. So this is her right eye. So you can see that scar kind of on the inferotemporal arcade. Here's her left eye. I can't see in very well, but you can kind of hallucinate, or you actually can see a detachment here in the periphery. And I think it's all coming from, this lesion. So, hand motion, vision, total retinal detachment. There's no surprise here. We're going to do surgery. So curious again, those who fix toxo-associated detachments, how fun are these for you? Lots of fun, not so fun. I hate to see smiling. So what do you think, Sumit? Tell me the challenges that are when you do a case like this.
So the hyaloid tends to be a major challenge. If it's still attached, it is very, very sticky, very difficult to elevate. If you can even elevate at all, oftentimes you're just trying to get as much of it off as you can, peeling as much of it. But it tends to be that tends to be a big part. And then once you get to the actual nidus of infection, that part tends to be an even bigger bear. And oftentimes you're doing large retinectomy in order to get this reattached.
Dan, your thoughts?
Same. They're just really sticky.
Yeah.
Sticky, messy case.
Do you have a B scan beforehand?
I think that's coming up. Yeah. I think it's right there. There's your detachment.
Is you have a lot of hyaloid separation, so I feel like
don't be fooled on this B scan.
Yeah.
This is like in these patients, it's like vitritis is like the vitritis in here can like fool you to thinking.
The acidic nature of the vitreous can actually make it look like you have the hyaloid up already, but when you actually get in there and you stain, it's like down.
And I'll
everywhere.
say we did this case and it wasn't fun, and total RD, choroidals as well. She was a choroidal scar that was inactive. I sent for toxo PCR. I did it under gas, and I was it wasn't smart because she came back and redetached. So I like to show everyone the one when I make
the
silly
one mistake you've made.
No, these are all learning processes. I think I went back and I always like to put gas in. I think I always like to put gas, eliminate the need for surgery. But I should have put oil in because here's what she looks like afterwards. So this is her afterwards. I mean, you can see this area. Look at the drag that's here. I mean, I shouldn't have put gas in. That was the appearance in the first time. I mean, there was drag already, and you can already see some of the challenges with this. This is taxidermy at some level, right? Because, we knew this eye wasn't going to see very, very well, just the nature. She was detached for so long. But the point or the interesting part of the story is not the left eye, is that 4 months later, she now has new changes in her right eye. She pressure's 33 or 37.5, depending who's checking her pressure, and 20/25 vision, cells in the right eye. Here's that lesion, that's popped up and already started. So now the other eye involvement. So I'm going to just walk you through how we do. That's the left eye still looking the same. I tap and injected, give her Clinda. Would anyone give Dex when you give Clinda in this time in the right eye?
It's a pretty quiet eye.
Yeah, it is pretty quiet.
Yeah.
Kareem, the South Americans like to talk about putting Dex in the eye. Your practice pattern
They actually put Kenalog.
Yes, and your practice pattern has not been that, right?
No, absolutely not.
No, yeah, I think we all have kind of shied away from that.
I like the prednisone tomorrow approach.
Yes.
After giving the antibiotics a day in the eye.
Yeah.
You can always stop the prednisone.
I suppose a lot of times we sort of presume it to be a diagnosis of toxoplasmosis because of characteristic findings. So if you felt like you were 100% certain, you already knew what happened in the other eye, I guess what's the drawback? What is the reason why you're sort of adamantly opposed to the idea?
Well, what's the upside? Because Dex washes out in a couple of hours. You're not if you're looking for the anti-inflammatory effect, you need it for weeks, months.
Right. No, that's why the Kenalog.
Yeah, but Kenalog though, if you don't control the infection, because sometimes the infection isn't controlled, you're now behind, right? So at least you can titrate prednisone on and off. So that's what I think is the key. for us. What do you think?
Oh, I would not do it, but
Okay.
I
just wanted to hear it from everybody else. I like it. I like that you
heard
did that.
some of the Brazilians say they did the catalog, and I was actually quite shocked. But I just wanted to play the devil's advocate.
So you want
on this
all
one.
these things. I will show you. I think Dan and I think actually all of us have horrific toxo cases that were treated with Kenalog in the eye. Like
It's just horrible.
absolutely the worst outcome that you can imagine. Complete retinitis, like looks like the worst case of ARN, and it is impossible to treat. Impossible. The tachyzoites love triamcinolone and love it, and they reproduce. It's like a party like no tomorrow. It's crazy for them. So anyway, that's why I haven't done it, because I'm afraid. I'm not saying I'm afraid. Yeah, I am afraid. I'm afraid of doing something bad to the patient. Okay, so here's the patient a week later. All right, and we treat this patient with Clinda at this point, taper, and here's how the patient does. The patient actually does pretty well. So now let's get to the treatment questions. I have a couple for the panel. So primary treatment for toxoplasmosis, that's my first question. If somebody is sulfa allergic, what do you do? When you do intravitreal clindamycin, well, I'll ask this in the different sorts of orders, but how often do you feel like you have to do it? And then we're going to talk about prophylaxis. So, Sumit, how do you primary treat most of your toxoplasmosis? So let's say if you're going to treat it orally.
I think oral Bactrim is my go-to for number one choice, and I also like it for prophylaxis. Now, if they're sulfa-allergic, that's a big challenge, because either you can talk to them about getting desensitization, but I think starting with clindamycin is very appropriate, and your other choices are either azithromycin. Downside with azithromycin is it may not be bactericidal, it may be more bacteriostatic. And then you can also do conventional triple therapy, although in the US that's not tenable anymore because of the price of the Daraprim component has gone sky high to like $800 a pill, and it still hasn't come down significantly. And then atovaquone is your other choice. So those are kind of your choices. I'm using Bactrim in the vast majority, and then either Clinda or azithromycin if they're sulfa allergic. But if it's vision-threatening, monocular, zone 1 disease, I'm giving them an intravitreal clindamycin as well.
All right, Corinne, so do you ever give intravitreal clindamycin only as your only therapy without any oral?
No, I have never done that.
You've never?
I always do intravitreal Clinda with oral medication.
And when you do intravitreal Clinda, is it only for zone 1 macular disease or someone who's had steroids?
It's only for vision-threatening lesions.
Vision-threatening.
Optic nerve, macular.
And
this is one exception where even if this was on the other side of it,
yeah,
I probably would have given it because she's monocular and did so poorly.
100%, I agree.
That's a good point.
So in South America, again, the primary treatment is intravitreal Clinda only, right? So I mean, they do that. There's very good publications on its effectiveness and how well it works.
So how often do you repeat it?
Yeah, so on their studies, they have said like the average number is somewhere between 2 and 3, right? My experience has been, I think, about the same, that I think you can get these inactive with somewhere between 1 and 3. And I will say that probably 2 is the...
So
2 is...
weekly then? How often?
Yeah, I'd give 1. And so we're about to show some data that shows that it's about 7 to 14 days before you see any sort of clinical response, which is still pretty fast. If you think about it, I mean, if you look at this patient... that's a couple of weeks. That's like 2 to 3 weeks, and you can kind of see it consolidating. But that doesn't tend to happen on oral therapy alone. I think unless you're on triple. So I think you have to be patient, which is hard to do when you have foveal threatening or nerve disease. Yeah. So I think we have a tendency to treat like weekly when we see it because we're used to treating weekly for other diseases like ARN and such. So I would do it probably once every 2 to 3 weeks if I was going to retreat, but I have no problem with doing it once a week.
So the interesting thing is the chirolysis plaques get a lot worse.
Yes.
So you go from 516 to 523, they're about the same, but at 6.6, even though the lesion is consolidating, those chirolysis plaques inferiorly look a whole lot worse.
Right. So you can see the plaques along the vessel here that are forming. But even from here to here, there's actually a little. I mean, again, maybe I'm hallucinating and it's consolidating. But look, I mean, complete consolidation. That's about 2 months, right? And this patient was on Clinda orally, and I believe he got 2 injections in the eye. So. Prophylaxis, how often do you use it and who do you use it for? So Yasha, do you use prophylaxis therapy?
I think for patients with macular disease, and I have not run into this situation where somebody is being rendered monocular from toxoplasmosis, but I think this would be an excellent candidate for somebody.
This one gets it immediately. Yeah. This one was getting it all the time. So now what would you...
So what is your prophylaxis?
Yeah, what's your prophylaxis?
Basically, back trim, three days, 3 times a week.
Yeah.
Yeah.
What if they're self-allergic?
So
Hard
that's
question.
a great question. It has not come up.
Desensitize them from their sulfa allergy and make sure.
Tried. I've got 2 patients who can't be desensitized.
Oh, really?
So what do you do for them? Both have macular disease in both eyes.
So I've used azithromycin in these, and atovaquone I've used as well. It's an older medication. We used to use it a lot in the HIV days. It's still the HIV days, but
So I've used azithromycin 3 times a week per ID's recommendation for the 2 patients that I have that have bilateral macular disease as their prophylaxis.
For bilateral,
500 milligrams
3 times a week.
Yeah.
Yeah,
What were you going to
because
say?
it third spaces, so its pharmacokinetics are completely different than any other antibiotic.
Yeah.
I usually give Bactrim daily for people who have macular disease in both eyes.
Yeah. So you do daily prophylaxis, and I've done both daily prophylaxis and 3 times a week, and I think I can't tell you that I notice the difference, but it makes me feel better.
It makes me feel
Yeah,
better.
no, 100% of
It
this.
makes me feel a lot
Is
better.
it dealer's choice, or is there some evidence sort of supporting one?
So I have one
regimen over the
patient
other?
who had steroid injections elsewhere, who anytime we go below daily has a recurrence within a week.
Really?
Yeah,
Yes,
it's the
Oh,
it's
it's that
the-
one.
that
Oh,
one.
yeah. Oh, my
Anytime
God.
she misses one dose within a
Exactly.
week, she has a flare up.
That's incredible. What about
She's
you,
tried
Dan?
it 3 times because she ran out of her meds
Topical?
3 times.
What's your prophylaxis of choice, and then if you couldn't go on Bactrim, what would you use?
Pretty much whatever already been said. Historically, I've done Bactrim, but daily, like cream. But that's just because later on the recommendations, like if you look at how ID uses Bactrim for prophylaxis for other diseases, they tend to do it 3 times a week.
Yeah.
So I don't know what the right answer is. I can just tell you what I've done. That doesn't mean it's the right. I think it's really dealer's choice.
Yeah.
I don't think it's firm evidence that one's better than the other.
No, I don't think there's any evidence
And
of it.
then if I have a patient who's self-allergic, then if I really want to prophylax, it'd be either azithromycin or Mepron. But I haven't written for Mepron in years.
Yeah, it's been a while. I mean, think about it. We don't do it too often.
Back in the day, it was actually a fairly expensive medication. I have no idea how much it is now.
Don't use Clinda for prophylaxis. It can
Yeah.
cause C. diff.
Yeah, let's
So
not use
I've
that.
done that, and I've done that. So don't. I
I've
agree.
had a hard time just treating people with clindamycin.
They
I feel
get
like people
bad
really
GI
hate it.
issues.
Yeah, they don't. Yeah.
Yeah.
They don't like it.
It's always fun to talk cases. I mean, I know we're videoing this, but it's just so fun. I mean, I really love what I do.
Tell them we do this.
Yeah, I know. I mean, for those, we do it every week. It's something we do every Thursday. Every Thursday morning is a strong part. And it started when I came here. Actually, the origination was when I was at Emory, and Dan had started retina rounds at Emory, and I was a junior attending, and we were doing those. And then Dan came up here. And then when I started here, Korea and I just loved talking about cases. Let's just start doing it every week. And this came from the NEI when I trained. This was part of your fellowship, was you sat and had lunch for 3 hours, and you talked about the cases you saw, and it was phenomenal. It was the first time we had and when Dan did it, they had to develop the film, so they didn't do it until dinner time. But it was the first time digital was there, so we would just run through cases. You would go to the cafeteria at the NEI, and then we'd sit there and go through. Now we're not the only ones, because I know the Hopkins people did it. I remember when I interviewed at Hopkins, they would do it. But it was something about doing it with Dr. Nassenblatt and Dr. Bugaj at the time, and you just sit there, and it was every clinic day. So that's kind of where it started. And then when Korea and I got together here, it was like, let's share some cool cases, and that's just kind of how it's coming. It was like, yeah, we like to argue, but more important, I think we like to learn from each other, because we all see things from our own unique lens, which is important.
I describe it to patients when I talk about we're going to bring your case to like a tumor board. It's basically that. It's a uveitis board, and it's on Thursday mornings, but sometimes it says another day of the week. And after your clinics on Thursday afternoons, you run more cases, and then we also have once a month for uveitis conference for our residents and fellows. So we do a lot of this.
It is. I don't know if we're taping this. It's interesting how the educational model has shifted over 15 years, because the educational model used to be, here's my lecture, I'm just going to show you this, and that's it. And now it's really, let's discuss it, because it's very nuanced. And I think it's a sign that we're actually getting better at treating these things, because it's nuanced now. Yeah. It used to be we were really bad at it, or we didn't have much choices.
There weren't very many choices, right?
We didn't have the imaging. Yeah. That's what I think it was. Is I think the imaging has fundamentally changed it all, and our therapeutics are thus a product of it. Anyway, we could go on and talk about that forever, but let's talk about other cases. 30-year-old female, bilateral blurred vision weeks, seen by an outside MD, treated with indomethacin, occasional headaches. She works at a supermarket. 2060, 2020, 1+ AC cell, 1+ vitreous cell. Here's her view in. I'll just share with you that you can kind of see the fluid kind of around here. You're going to see this on the fluorescein and on the OCT, but you can kind of see these pockets right here and another pocket here and around the nerve here as well. All right, so not hiding anything, all friendly. Here's the fluorescein that kind of, again, highlights it, that you can see it here. So, and here is the ICG that you can kind of see the hyper, but what I'll point out is actually a lot of these things that are hypo are very real. So a lot of these things are actually real here. So, you know, Yasha, what do you think? What are your thoughts? Like you see something, oh, I got an OCT as well coming at you, sorry. Right there, there's your OCT. So see this and anything that kind of comes to your mind when you see this thickened choroid, subretinal fluid.
Right.
What are you thinking here?
Yeah, so the most common probably in this differential is VKH. She's never had any surgery, correct?
No surgery
And
whatsoever.
then the other thing is the rare circumstance of bilateral scleritis, like posterior scleritis. So, so I think I'd probably do a B scan just to help differentiate between those entities. But you have some more classic features. You know, so I would want one more B scan before I kind of confirm a diagnosis.
Gotcha. Anybody else? Anything else in your differential?
I would think TB or sarcoid.
So TB and sarcoid as well in the differential as well.
This was acute onset? Did you notice
This was
her vision?
relatively acute. Yes, sir.
You said she's Caucasian?
She's 30. She's Caucasian. Yeah, she's Caucasian. She's probably, I don't want to say darker skin Caucasian, but you know, she's brown haired, you know, but yeah, she's Caucasian.
And on the past medical history, she was having some headaches. Was that?
She was having occasional headaches, but occasional headaches. She's like,
Yeah,
I work
okay.
too hard, I get
No-
headaches.
no
But it wasn't
ringing
like
in
the
the
primary.
ears.
She wasn't
No
like, oh my
tinnitus.
God, the headaches are horrific, or I don't have any
ringing in her
hearing
ears.
loss either.
No tinnitus, no.
No tinnitus, no tinnitus whatsoever. Okay, so
And no Native American.
no Native
ancestry,
American
no?
ancestry, no pigmentary ancestry. So she, as far as she knows, she doesn't have any Middle Eastern heritage. But you know, she admits that she doesn't go back that far. She hasn't been on Ancestry.com or anything.
And she
like
didn't
that.
have any. She didn't have any skin findings.
No skin findings, no vitiligo, which would be odd even in the acute setting, right? But no, but you know, maybe she's had some other things and no loss of hair or anything like that. All right, so I think we got it kind of talked about this, but I think the fluorescein and the ICG kind of point us towards VKH. Sarcoidosis, I think, on our list. So we did a workup, and her workup at this point is completely negative. So, you know, it's someone like this, Sumit, who you highly suspicious of VKH. Is this someone you immediately immune suppress? Like, is this somebody who goes on systemic corticosteroid sparing immune suppression?
So I think it depends on how she responds to prednisone.
Okay.
Right? So if you do a course of prednisone and it very rapidly resolves everything and she looks great, the ICG looks good, you can watch them and watch the ICG especially very closely for recurrence of the hypocyanescence lesions. Because oftentimes what you miss is having some ICG disease, so choroidal disease is still there. The retina looks good on the fluorescein and the OCT looks good, but you're missing the smoldering choroidal disease. But if they're not having anything on that, then I'm okay with it. But if you're tapering the prednisone and you can't get down to like 40, 30, 20, and you're already having recurrences, I'm thinking about something long-term.
Yeah, that's what happened to her. So she got better, completely resolved, and then blurry vision once she gets down to 40 milligrams.
That's amazing because usually when they recur, it's 20. In my, but you get it at 40, that's pretty high dose.
Yeah, so
You gotta-
she's
Is she pretty big?
Yeah,
no,
so
she's a
what-
thin
that's-
woman. She's like
that
not,
does.
I made her big with the prednisone. So, in someone who has a VKH, Corinne, what's your steroid dose like for that initial time? Is it on the higher side, or you?
It should be on the higher side.
Okay, so like
At
for you, is it
least-
1 mg per kg, or is it
At
higher?
least 1 milligram per kilo.
Yeah, and Corinne, I know you've been an advocate of this. How often do you IV pulse these patients?
Quite frequently.
Yeah.
Especially
think
if
I'd be-
they
Yeah,
get worse.
the years and years ago, the Japanese literature suggested that very, very high doses up front had some long-term benefits. The data wasn't overwhelmingly convincing, but they were our colleagues who were treating this way more than we were. And so, like Corinne, I sort of adopted an approach of very aggressive steroids up front.
They were starting at like 200 milligrams.
200 milligrams
Yeah,
is standard, or pulse IV, that's right.
We're not
200
going to
was
do
the
that.
standard.
Yeah. I think the good news. I mean, I think that comes from. I think now we know it's got to be the choroidal and the RPE changes that are occurring. Like if you let that sit, you're losing RPE for sure out of retina. Like, it makes sense now. Quickly get that retina back into its correct orientation, right?
So do you routinely check a blood sugar before you start with someone on high dose steroids?
Well, I do, because I'm doing labs anyway, because I'll check their sugar, but I don't do fasting.
But if we do IV salmeterol here,
Yes,
the OR automatically checks the blood sugar.
Yes, exactly. If we're IV salmeterol.
So I asked the question because that's right. I mean, you need to do that.
Yes.
My one of the most memorable VKH patients, 35 years old. She's hand motions OU. African American with some Native Cherokee ancestry. Put on oral steroids, fantastic result. 2025, 1 week later, these patients exquisitely steroid sensitive. She was doing great. She was a thin African American woman. I'd ask her about diabetes. She said, no. I didn't check her glucose. 2 weeks later, as I said, when you can't come off this, the biggest mistake is you respond VKH and you go too fast. You can't go fast in these patients. 2 weeks later, I saw her 1 week. 2 weeks later, she's admitted to a peripheral hospital with hyperosmolar, 2,000, glucose of 2,000,
Wow.
2,000, and repeated at 2,100.
Wow.
So it was real. And so
Just when you were in the South, you sure she didn't have any Kit Kats or anything like that? Well, she's doing
That's right.
She was drinking sweet tea.
Was it a sweet tea? Was it
IV
the sweet
sweet
tea?
tea.
So she stopped. So they abruptly stopped her steroids.
Yeah.
Oh.
And she comes in to see me about a week or two later, and she looked great. And I was thinking, oh, maybe all that stuff I've been told was not right. Holy smokes. When she recurred, she was LPOU with exudative attachments up against the back of her lens.
Yeah.
The most impressive case I've ever seen of this.
It's amazing.
Yeah.
It's amazing. All right, so let's go through. Here's 80. Here's now, I was getting better at 80, but recurring at 40. And, I decided, I can't get her down. So I put her on immune suppression. I'm just going to say I used adalimumab on this patient. Talked it over. She already had one screening MRI. So she already had an MRI done beforehand. MRI is clean, quiet for 5 months. She's doing great. Then she comes in. She's got some mild pain in her left eye, and it kind of hurts when she moves her eye around. She's completely quiet. Her vision's 20/25, 20/40. It's actually one of our former fellows who's here, was really sharp and figured this out. So new eye pain in a person who has this appearance. It's very, very mild.
Optic nerves look.
Her nerve looks fine, but she does have red DSAT. So she has a red DSAT on that side. So she picked it up that the red DSAT was there. She has some mild numbness and tingling. We sent her to the ER. And it turns out she has some demyelinating changes on her MRI, which are new. They weren't there beforehand. So, just for the arrows pointing out where they all are, just in case you weren't sure what it was. And, so I guess I was just going to ask you, bring this up, kind of how often have you seen it? And the numbers obviously are low. But, Sumit, Kareen, Yasha, Dan, tell me your experience when you have a patient like this. Does this become any easier or any harder? Was this MS all along? What do you think?
I think this is sad, because if you can't get below 40, you're not going to sort of build up your dose of Cellcept to a adequate level in time for her. You'll have all of the consequences of high doses of steroids. I think I always sort of wonder in these cases where they recur at high levels, whether we should be a little bit more aggressive about treating them locally bilaterally, because there are huge consequences to being on high doses of prednisone for long windows of time.
And there are a lot of people who advocate perioculars early and used to be perioculars. Now I advocate intravitreal therapy like Ozurdex or Triessence in these patients. And I think that makes a ton of sense. I know I've done it even in young people to kind of bridge them at this point, and I know Kareen has as well as Sumit. But these scenarios, you're right. So, mycophenolate, methotrexate, all of them take a while to kick in, and man, we were doing so well. So Sumit, what did I do wrong, man? Did I do anything wrong?
I don't think you did anything wrong.
Thank
I don't
you.
think this was MS in the beginning. I think this was VKH, and you had an MRI already, even though you wouldn't necessarily get one at baseline.
Yeah.
This happens occasionally, unfortunately.
I've had anti-TNF induced demyelination that goes away after you stop the Humira.
Yes.
So it's not something permanent.
So this woman.
Well, so that's what he's talking about. That's his second point there, right? Is the TNF later is required for control of the inflammation for MS. So
Yeah, and so if you look, Arthi Venkat wrote this out for us. Chicken or the egg? Was it true MS or was this TNF associated MRI spine, which was focal signal abnormality consistent with old demyelinating disease, or LP is positive for oligoclonal bands. Neuro thinks this is more likely MS than anything else. So the question is, was the uveitis MS? And that's not classic MS-associated uveitis, so I stopped the MLN. She's been difficult to control. She had another episode of demyelinating disease, and these are the two questions I'll end with. Thankfully, she's controlled now. We have in our B cell, essentially a cousin. It's a cousin of rituximab. It's one of the.
It's the new one.
It's the new MS.
The new anti-CD20.
Yes,
MS
it's an anti-CD20 drug. It's actually working great on her. She's doing great. She's wonderful. Everything's going really, really nicely.
I've actually had good luck with these TNF-induced demyelinating syndrome, then going on anti-CD20 and doing really well.
It took me a year. It took us a year to get her recontrolled. I had to give her periocular, give her intravitreal. Yeah, and these are hard, but we got her onto. Neuro was incredibly helpful in this. We just went through and said which one we're going to use. We tried mycophenolate, didn't work very well. Then we went to the anti-CD20.
Yeah. The interesting thing is the one that I put a Retisert in, now she's almost 5 years out, hasn't had a recurrence in the eye on the anti-CD20.
Yeah, it's great and it's wonderful. So let me ask, before we start anti-TNF in a young female, 28-year-old, you getting an MRI, no neuro symptoms, completely healthy, everything's going great.
Yeah.
Yeah?
Yeah, I think I'm just super conservative, so I always check it.
Does the insurance company pay for it?
The nice part about it is I have a rheumatologist who also strongly advocates for it.
Yes.
And I think if I can't get it, then he also will try to go and fight for the prior authorization.
I think you can get it. It takes a little bit of work. Corrine, what are your thoughts?
I think we should get it.
Okay, you think you should get it? Sumit?
Yeah, I think you should too. I think if you're going to start them on anti-TNF, young female who has uveitis, you've got some concern there.
I've vacillated on this back and forth because I've asked everyone, does it, if it's negative, does it mean it's not going to happen? And of course it doesn't, right? We have enough cases.
Unfortunately, there's awful litigious component to this as well, right?
Course,
which is one of those things where, because it's a well-known thing, could you have potentially made a better decision? Right. And you can see how this goes downhill for you if you end up in this situation where this is basically gets progressively worse for her.
Absolutely. Yeah.
All right. Do you start anti-TNF on someone whose family relative has multiple sclerosis?
That's a great question because I know we've shared cases like this. I get an MRI and then we all sit there and say, what's the right thing? Because the MRI equivocally is negative, right? So then I sit and I say to the patient, well, you have a very strong family history of this, and we know this drug plays a role. So I will say probably the majority don't go on anti-TNF. Yeah. But I have put people on it, and so far so good.
I have too.
Yeah.
And are you saying they've already failed antimetabolites? Is that the
Right.
rationale? Yeah.
Exactly.
Has anyone used anti-IL-6 in VKH?
I don't know the answer. I'm sure there's probably case series on it, but it's so hard for us to get unless you fail other things. So at this point, it's fair.
I haven't used it. I don't know if there's any data on it.
All right, so this is a 82-year-old male who complains of a decrease in vision and worsening floaters in his right eye after cataract surgery about 2 weeks ago. He had it done it was uneventful, and while he was tapering his Pred Forte, the ophthalmologist noticed white dots in the retina, and vision went from 20/50 7 days later to 20/500 about 2 weeks later. And he does have a history of intermediate AMD in both eyes. He's got a pretty significant past medical history. He's had prostate cancer, then he had radiation and resection. He's had a history of kidney stones. He's had a hemorrhoidectomy, a hernia repair, the prostate biopsy and debridement, a cystoscopy, a urethral stent. And as a child, he actually had a bowel obstruction. He's on the medications listed there for his blood pressure. Family history of renal cancer in a sister, heart attack in a brother, a stroke in a brother, CHF in mom, and an embolism in his dad. He complains of headaches, hearing loss, and he was recently hospitalized for bradycardia, and the workup was otherwise negative. So quite a bit going on. 2200 in the right eye, 20/30 in the left, and this is what he looks like. So kind of similar to the very first case we showed, but also slightly different. So Yasha, what do you think?
I mean, you have sort of dense vitritis, and then there's sort of multifocal deep retinal whitening out superior temporally with also some associated hemorrhages. This vitritis may be such that you may be able to get an OCT through the sort of temporal macular one to understand what layers of the retina are involved. And because your differential is really, in this case, very likely some sort of infectious etiology versus a neoplastic process, so like a lymphoma.
Yeah.
So that's
and
sort
what about
of
infectious? What are you thinking?
What's that?
For infectious, what are you thinking at this point?
Well, I think whenever you see this, especially with an optos, a hazy view, you have to treat it as an ARN. I think the downside to doing that is very, very low. And I think sending an AC tap is a very reasonable first step, because the other one is going to go much slower in the evaluation. But if you're wrong on that first one, you've lost considerable ground.
Yeah, I think that's very reasonable. And here's his other eye that looks fairly normal.
So if you go back. So I agree with everything Yasha just said. This one, kept looking at it and thinking, yeah, ARN's got to be in your differential, but look at
They're deep.
this
You
is
can
all
see the vessels
subretinal.
over.
That's
Yeah.
That's
exactly where I was
what
going.
makes me-
They're very
Subretinal,
deep.
and look at the pigment, look at the RPE stippling over the top of it. Boy, that smells a lot like lymphoma to me.
It's interesting how we all say it smells like lymphoma.
Smells like lymphoma. Sorry,
Sniffing your patients again, Dr. Martin.
So here's the OCT.
Yeah.
And you can see that there's a little bit of outer retinal changes in both eyes. Is this his AMD? Is this chronic? We don't know. This is the first OCT he has in our system here.
But you would say that OCT, at least the temporal aspect of the right eye, is suspicious, right?
it's very suspicious.
When you have that sub RPE elevation and that thickening of the RPE, and it's asymmetric from the other side. So if it was an AMD, it'd be a little odd. I mean, I think it goes along with everyone's thoughts here that a neoplastic or a lymphoma is probably high on your list.
Yeah.
Yeah.
But with that said, are you reliant solely on the imaging and your examination to say that you would not go and do an AC tap and
No.
treat
And
as
history also.
What's that?
History.
History.
History, I think,
yeah, of
history is
course.
important, of course, but and of course you can't ever say 100%, right? Because we've all, we all have had the case that's odd. But I think when you have this much stuff, all of a sudden you're saying, it's really my differential. Usually we say lymphoma is low. This one's like it's zooming up
It's
the
zooming
chart.
up
So
there.
it's not like number one. Well, maybe it's number one, but it's not number 10 anymore, right? So you have to have it. I'm thinking about the next step of making sure I rule that out too.
And here's his fluorescein. We can see that there's quite a bit of outer retinal change, that RPE change that we were talking about. And then as we get later, there's a little bit of staining, a little bit of leakage, a lot of staining, but that RPE change is pretty dramatic, and it's very, very widespread. It kind of spreads out all the way out into the periphery here.
And importantly, no evidence of necessarily ischemia, right? So there isn't any vascular non-perfusion, which
Right.
would fit with more viral,
Right.
And then your punched out kind of appearance there, again goes to I think what you were thinking, Sumit.
Yes, and his other eye looks pretty normal, but here's the real OCT over that
And
lesion.
then,
You can see
yeah.
that these are very, very deep. So what are you doing now?
I mean, I think at this point you have certainly enough imaging evidence to go for a diagnostic fit.
Right. And I mean, I think you should rule out the quantiferonase and syphilis and then go for a diagnostic fit was the plan.
Right,
here.
and this to me, when I see something like that, when I just saw the macular OCT, I would have still probably gone and done an AC tap and just put some antivirals in the eye, just for my own peace of mind, and then plan to do a diagnostic fit.
Even with this OCT?
When I see this, I'm not going to do that.
Right.
now.
I
You
sent
know,
the patient to
so-
submit.
What's that?
I sent the patient to submit.
Gotcha, yeah. Yeah, to me, this is what I think really sort of solidifies the
Right.
deal that you are not dealing with the viral retinitis.
So I think the sending the patient back down to get the OCT through the lesion really changes your management plan, and so that's why I think it's important to get that, and that's what was done for him was go back and re-OCT it. And so he gets an MRI, just shows nothing significant other than some old probably hypertensive disease. Some hypotensive events in the MRI, and his syphilis test and CBC and BMP and UA are all negative. His TB test is positive though, but very barely positive. So do you think it's TB? No, still thinking it's lymphoma.
It's not. I mean, in India, yes, it's
Yeah.
always TB, and in some parts of the world, it is. But it's still lymphoma and TB.
Right.
And go back to the OCT. So it's, there's a sub-RP localization. You can see actually outside of those large PEDs where it's a little bit flat, you almost have like a double layer sign where you can see Brooks membrane underneath it. So it allows you the opportunity to know that this is not a choroidal process, and it makes you feel much better in ruling this out, that this is not related to the
TB.
positive quantiferon.
So, what are you doing for your diagnostic vit? Are you doing vitreous only? Are you taking retina?
Oh, vitreous only.
Okay.
I'd probably do the vitrectomy and probably make a little hole next to that lesion and just aspirate some of the subretinal stuff too.
So
On first pass?
the more gray hairs you get,
This is really interesting because you and I are the same, and
the
these
more,
two are the
the
same.
more
way.
the more gray hairs you get, the more you realize, I think an important point, which is Dan's getting to, that implies chronicity. Chronicity means the vitreous biopsy has a higher likelihood of being inflammatory only or missing it. And I've been burned now a couple of times where I thought, I'm so smart, I know this is lymphoma, I'll just do that, and I don't take it. And I've now regretted it like 1 or 2 times. Now that every time I see that, I go after it.
But what's the drawback of just doing a vit and then saying when it's negative, going back and saying we'll do the...
So you could, and so...
I'm going to show you what the downside is right here.
My practice pattern, and I've done lots and lots and lots of these because I got plenty of gray hair. Probably
I see them back
15
here.
years ago, I moved to doing, if there's a subretinal lesion, I'm biopsying it because I had too many negative vitrectomies. Now, has the diagnostic sensitivity improved over the last 15 years? Because if it has, then maybe I don't have to do that. So, but I've been burned too many times before.
And I think we're cytology based still, right? So if we were, and we do flow on these as well. So we do cytology and flow. And if we did, like, if you based it on IL-6, IL-10 levels only, or you did...
And how about MIDI-88?
MIDI-88. If we don't do MIDI-88 here. So that's the thing. I mean, I think if you did that...
So here's the reason we don't do MIDI-88. If everything else is negative and your MIDI-88 is the only thing positive, what are you doing? Are you treating them for lymphoma?
Yeah. And I think this is very much like a neuro-oncology. Like how do you work this together? Because this is a team-based
because the
bunch.
oncologist won't.
Right. And I say the downside, Yasha, is that thing will get better spontaneously by itself. So the subretinal part could actually all improve after your vitrectomy.
Yeah. So this is really interesting. So it comes back as low cellularity, almost all T cells, essentially no B cells. We sent cultures because we were there and we didn't want to miss it, but I did vitreous only. And this is a learning one for me because now what, right? So he gets that. We're going to have him back the next week for another diagnostic, but he gets lethargy, goes to the ER. He's driving to the retinal biopsy with his family member. He passes out in the car on the way to doing the biopsy, and gets admitted, gets an MRI brain again, and now it shows multifocal lesions that are signal abnormality. They're concerned about CNS lymphoma. He gets 2 high volume LPs. Neither one of them are positive for lymphoma. They're very inconclusive. And our neuro-oncologists are very reticent to treat someone as lymphoma unless they have a tissue diagnosis. And so then I'm going back in.
And you can see how many weeks after?
This is this is 8/27, and
so
the original
weeks.
one was
8/6.
Yeah, 8/6.
So not even 3 weeks.
And 3 weeks later.
But suffice it to say, you I'm not sure. Like the CNS component is sad, but I'm not sure that wouldn't have been altered by knowing.
You would have treated earlier, but look at how much worse this is.
Oh wow! God. Oh yeah. That's way worse.
That's surprising. I
went in and I was like, oh wow, because we hadn't been able to see him because he was
remarkably aggressive.
Well, at least the good news is you have a lot to choose from.
Yeah.
it's terrible.
So we did intraoperative OCT.
Was that the original one there on the left?
Yes.
I'm sorry, nasally.
The temporal side was the original.
Temporal side is the original.
So
that's
like
right. The nasal.
Yeah, it was supratemporal. The nasal is brand new. I mean, it just looked very, very deep.
You can see now. Yeah, you can the hemorrhage.
I've never seen it grow that fast.
So this is 3 weeks.
I've had one case like this, and it just like zipped like this. And usually it gets better. This is weird. Yeah.
So I've had one case where it was from aura to aura, subretinal space. You see the RPE stippling, classic for
Yep.
lymphoma, right? So, but the
And I wanted to take the newest one, and that's why we went for the nasal
Yeah.
side, because I was worried about necrosis from the old lesion.
yeah.
Just because of how
So,
fast
so,
it's
so what I used to always do was just make a little retinotomy and just put a soft tip, like the green tip, a long one, just aspirates like
Yep.
chalk.
So the interesting thing is I wanted to make sure we get a diagnosis
Yeah,
here
yeah.
because we had so many
That's
inclusive.
reasonable.
So I didn't show this in the video. We actually put the cutter into the temporal one
Yeah.
and took a sample of that. That came back negative because I
really?
sent it separately for cytology, and
Wow.
they said that
Wow,
was
that's amazing.
necrotic. No diagnosis made from it. So we mark with diathermy, laser the edges first, and then I go in with the vertical scissors, the pneumatic vertical scissors to separate this and make sure that we get all of that lesion separated, and we get the retina, subretinal space, and the choroid and the RPE, all of it with the vertical scissors, just separating it all.
So nice that it's all nasal.
And so there's the retinotomy there. You can see that I made this. This came back
wow.
negative.
Wow.
That one came back negative for lymphoma.
Wow.
And the only one that was positive, and I sent it all separately. So I sent our retina and subretinal space, and then I sent choroid and RPE. The choroid RPE was the only positive biopsy. Everything else was negative for him.
Would you ever consider doing this with a 27 gauge cutter now, like the Bevel 27?
Could do that too.
Yeah, sure. You can. I mean, you can. I mean, there's so
So
many. ways
that thing was negative.
that,
The whole
that-
thing?
This thing is negative.
That thing's negative.
Oh,
The
yeah,
only thing that was positive was the RPE
yeah.
choroid
No,
complex
I would
that I
anticipate
sent.
that the retina biopsy here is negative
Yep.
because it's.
But there was
the
so if you go back and you actually look at it, there's these two big, as it comes off, you can see it.
Oh, yeah. well,
That big
Yeah.
whitening area,
But
that
was
came back
negative?
negative.
But that fell off by the time
Yep.
it came out because you can see it because you
Yep.
can see it floating around. That thing is about to wash off
Yes.
because it's so.
But I even sent cytology on the fluid that was floating around and the white debris that was floating around. All of that came back as necrotic cells.
I hate when this part happens
Yeah,
when it
me
gets
too.
caught.
They're so worried
Yep.
about that. Get that stuff
Okay,
out,
so
yeah.
from now on, Sumit, are you going to biopsy the lesion?
If there's a retinal lesion, I'm taking it. from
Getting
now
gray
on.
hairs, Kurt.
Yep.
He's getting gray hair.
This is the first one where I have not had it come back
But,
positive.
you know, here I'm a little. I wonder, should we be making like decisions on the worst case anecdote, right? Like
ahead,
this is
go.
But I think this is
So
a
the
very
interesting thing is
point.
you can test for this, right? So you can send your vitreous separately from the rest of it, and you can see what your diagnostic yield is. And that's why I sent the 4 samples separately. I sent the retinotomy sample, the retinal biopsy, the aspirate of the stuff that was subretinal, and then the choroid. The choroid was the only one of the 4 that came back
So
positive.
if I was being critical, which you know I am, I would have said that on this piece, I'm not sure I would have done a full thickness. I think I would have just done a subretinal,
Right.
just because like of how it looked, you know, that lumpy, bumpy appearance. I think I would
but
have
that
done.
was negative.
Oh, but really,
No, but I don't. I think your sub RPE would have been. What was the thing that was positive? It was
The
the
positive was the choroid. It's the
the
only
choroid.
one they said positive.
But I think your cell. I think some of that is because the cells were like kind of floating in there.
I aspirated them.
Yeah.
I aspirated those cells before we took the RPE, and
Wow.
they were negative.
That's crazy.
But
What
I
a
think
crazy
this
case.
is a great case because
Yeah.
it shows you that those lesions become necrotic.
Yeah.
So
Yeah.
you really have to go for
So
the
you have to go for the subretinal
new,
space.
Yeah.
new lesions.
And it's incredible. I mean, so they diagnosed it as a very aggressive B-cell lymphoma, and even on the choroid piece, they said it was very necrotic already.
Wow.
And that was the newest area that we biopsied.
Wow.
So he did very poorly because of how aggressive this was. He got started on systemic rituximab and methotrexate. He was transferred to the ICU for increasing lethargy,
Oh,
and
sad.
then became septic with bacteremia, was minimally responsive. Then he got placed on hospice, and I actually just got a call from his family yesterday that he's actually doing better.
No, that's great.
He's feeling a little better.
Awesome.
He's still on hospice, but he's communicative now, and they were just very thankful for getting a diagnosis, even though I think we delayed significantly.
You know what's interesting is that these are super responsive, right, to therapy, and
It
at
just
least
took a time
you
for him
get
to recover.
you get this like a little bit of improvement before, unfortunately, there's like worsening, and there are some people that I've met that have like brain disease, and I'm convinced they're going to expire quickly, and then like
And then
all
they
of a
do
sudden
okay.
they
I mean-
perk up. But I mean, unfortunately, the disease does get you at some point in time. And
Yeah.
this is a hard disease.
This is very hard disease.
And you're right, Yasha. You can't make big generalizations off of one case. But I'll say that now, having done these now for a while, it has been, and it probably was in the last 3-4 years that I made the switch over, because was like, and I think Sumit and I were in the same spot. Like, why go after a subretinal component? It doesn't make sense. We're doing damage to the retina, and very clearly became, if I don't get it here, I'm just delaying this next process. And we're looking, a lot at this now, and I think this implies to me that at least these patients have chronicity, and that's going to make it more likely inflammatory cells.
So the interesting thing for me is I had that same opinion, but I was always like, well, you can come back next week, right? Yeah. So a vitreous biopsy is so low risk in our hands nowadays, the way we do it, that why not just come back a week later and do the retinal if the vitreous is negative? And this is my reason why.
Well, this is the rare case, right? The much more common case that we have is that of primary vitreoretinal lymphoma, where we're doing surveillance for CNS lymphoma, and a lot of them, knock on wood, have been doing actually quite well, and we don't have CNS disease, right?
But we don't know that a priori, right? He didn't have CNS disease. He got the MRI pre the retinal biopsy, the vitreous biopsy.
That's right. We don't know that, which is, when you think about what's the visual outcomes between, this is somebody who ends up under oil. The other person ends up with 20/20 vision from a vitreous.
I would actually say that just if you're doing a cutter subretinal biopsy and you're doing it is small enough, you can just do gas, and the gas will go away, and they do really well.
I do most of these with gas. Yeah, yes. I do most of it with gas.
With the cutter subretinal, I do it with gas.
And then ultimately they get intravitreal methotrexate, which makes the retinotomy flatten immediately.
Yes.
Oh. Yeah. So I'll give it to them after I get the diagnosis.
Right. So when I get the diagnosis with gas in the eye, I'll put methotrexate in, and they do really well with those.
Yeah, it's
pretty. I've always done them staged. This case is the one that's going to make me not do that anymore. All right, so this is a 32-year-old with vision loss in both eyes for 2 years. She's been treated by an outside doctor for MUDES for 2 years. She's had a very extensive workup there, including our standard workup and many, many, many more. And she's had PSTK in the left eye and had been started on Humira before I saw her. And had been with this diagnosis of MUDES, had the PSTK, and everything else was negative. Otherwise, a young, healthy female, no family history. 20/20 in the right eye, 20/60 in the left eye. She's got some KPs on exam, 1+ cell in the AC, and then 4+ cell in the vitreous with 2 to 3+ haze in the right eye. You can see that here. And quite a bit more haze in the left eye. So, Yasha, since you haven't seen this case, what do you think?
Yeah, this is hard, right? So I guess the question is, in this searcher, you have essentially some follow-up, right? And if you have a working relationship with this doc, I think it'd be wonderful to see the images beforehand. So
this is here when we see her.
This is okay.
The right eye, pretty normal looking. Maybe something in the vitreous here you can make out, but maybe not. And then in the left eye, you can see an ERM and CME.
Yeah, and then also sort of thickening of the RPE as well. Very hard to make out the ellipsoid zone. Clearly seems attenuated, but it could be a problem with shadowing from the vitreitis overline. So it's hard to make much sense of this. I think in these circumstances, I frequently just go back to the drawing board, and I would actually go and just work them up de novo.
Okay.
So let's see an FA and
There's
ICG.
Very difficult
but the
view.
workup was quite extensive.
Yeah, and I guess it depends on when it's done, right? Because, it's a cross-sectional moment in time. So say that workup was done like 2 years ago, which is when the patient may have presented. I think it's not unreasonable to go ahead and do it again. So that would be my...
What would you repeat?
I would just
so you're not
almost
repeat
as
a
if
B27.
I'm not going to read that because it's
change.
a genetic association.
Right.
So she's 32, she's female. What I would probably end up doing is I would check a quant, I would check a syphilis, a lysozyme, A29, and that would probably be where I would start at this point because you didn't...
Here's her ICG.
Yeah, and you can't make much of it because of the density of the vitreitis, unfortunately.
Right. And here's the other eye. Again, density of the vitreitis makes it
in a case
really
like
hard.
this, when you have recurrent inflammation and uncontrolled, right, you have to, essentially get a handle on whether it's truly the inflammation, she's undertreated, and are we on the right path? So if you, from a workup perspective, right, it would be like sarcoid is the thing that you can miss, right? That's a masquerade, but she's on immune suppression, and she's done courses of prednisone, I think, in the past.
Yes, but we don't know how much of a response she's had.
So, you know,
I put her on prednisone at this time.
yeah, I said at this point, what I would do is I'd start somebody.
I want to see treatment response personally. I
Right,
want to see how
exactly.
she does, and so I would re-challenge her with prednisone at this point.
And you guys wouldn't do any lab workup at this
I
point?
think we confirm it because TINU would be the other thing, but like to me, this is not infectious. I hope it's not infectious, but you know, we want to make sure the syphilis is negative, the TB is negative, right? It's not going to be toxo, it's not going to be fungus, right?
Not
it's
for
going
2
to be,
years. It wouldn't
it's
have,
going to
it would have
be
blown up by now.
something like it's either inflammatory or it's masquerade, right? Those are the two things I think.
So I put her on prednisone at 1 milligram per kilo to see whether she would respond, and she didn't come back.
Oh, she did not come back.
She didn't come
She
back.
comes from
so
a couple
I
hours
couldn't
away.
tell whether she had responded or not. So by the time
Right.
she came back,
So when she comes back, her CME is better with the Durezol, the difluprednate, and the prednisone, but she recurs. And the vitritis at this point has not changed, but it's been a while since she's been off now. So now it's 5 months later. She's 20/25 in the right eye. She's 20/70 in the left eye. So now what are you doing? Are you
She's
re-challenging her and
she's
telling her
on
to come
prednisone
back?
or she's off prednisone?
She's finished the course.
she's off.
She's off. Or she's on a tapering dose, I think, right?
No,
Or
I
she-
think she's finished
she
at this
fin-
one because
she
it's been
finished.
5 months because she didn't
Oh,
show
she
up.
finished it. Yeah. Okay, got it. You're not making this easy on you.
But her vision's better. She was 2200, now she's 2070.
She's a brisk 27. She's a 2070 is
That's a
brisk
horrible
2200.
2070.
Yes.
You know, and
And now her CME had gotten better, and now it's recurring a couple months later.
you know, one of the things, where does she live? Like, is there like a reliable doc that she can see nearby? If it's a problem of distance, sometimes you can re-challenge them, and then if that doc has Optos, just serial Optos imaging, especially if the settings are the same, can provide you some understanding of improvement in the vitritis. But in this circumstance, it's really, really hard. You're like, you know, you're kind of forced to go and say, do you take this person for like a diagnostic vitrectomy at this point? You know, like.
Here's what her cells look like. These are slit lamp photos of both eyes.
So she was sent to submit.
Yep.
Yeah, so I think in this scenario, what the two things are the vitritis that's so dense that doesn't get better.
Right. That worries me.
That's probably it. The red herring here was the CME. The CME, you know, is not classically associated with anything, you know, in a phakic patient, but the fact that the vitritis doesn't get better, or at least it's like stubborn enough. And you see this was, Karina and I both said, yeah, it's time to
Right. It was time to take them.
Right.
time to go
Yeah.
for a vitrectomy.
It's so hard in the setting of non-compliance, you know, to pull that trigger, right? Because you don't.
So she had been back on prednisone at this point, so we stopped the prednisone and we took her for biopsy. A week after, I wanted her off the prednisone for 2 weeks, but a week after stopping it, she had a dramatic worsening of vision. She dropped at hand motion in the left eye. And so I moved her up and did her that same, the next day. And
as soon as you touched this eye, you knew what
Yeah.
it was. Like, I mean, that vitreous
Yep.
right there, that's
there's
one thing. That's either an infection or it's lymphoma right there.
And so we took it out, very, very dense, and it came back positive for lymphoma in a 32-year-old that had been going on for
That's
2 years
brutal.
at this point.
Yeah.
And now she has had, she actually had negative MRI, but did end up getting systemic treatment because of the bilateral involvement. Neuro had a long discussion with her and chose to treat her. She decided with them to treat systemically so that
What was the treatment that they opted
they
for?
went cytarabine.
Interesting.
And
Yeah,
then
this
she's
is-
gotten intravitreal methotrexate times 6,
Yeah.
and now I'm watching her because I was waiting for the subretinal lesions to go away because that fine granularity on the OCT was improving with each one. And I did a total of 6 methotrexate injections. I didn't do the classic, the bi-weekly and then weekly because she was getting systemic. If she had just done local, I probably would have done that.
Yeah. This is the youngest one I've seen.
This is the youngest I've
Yeah,
seen.
it's really.
29, probably 30.
Yeah, 29 when her
I think
symptoms
the
started.
youngest is 14 in the literature.
Yeah.
There's one I think Lucia Sobrin wrote about. That's amazing.
Yeah,
It's crazy.
That's beautiful.
there's her cells.
Beautiful case, sad story. But, you know, we still in the middle of it.
Yep.
You know, I have somebody who was diagnosed in his 30s and he's 50 something now, alive.
Yeah. So we will see how she does. So you can see with the methotrexate, some of that outer retinal stuff changed. Yeah. She's very happy. The outer retinal changes are improving, and so I treat
How
her.
are you doing the methotrexate if she's coming from far?
She's coming once a month.
She's coming once a month.
She's coming once a month for her cytarabine. She was going to get 6 cycles, so we gave her methotrexate with each of the cycles. Because she gets admitted here for the cytarabine.
So it's sort of less frequent than what we would otherwise normally be doing, but you feel like that's working.
So I don't think I know, right? If she wasn't getting the systemic therapy, I would have pushed her to do the classic biweekly or radiation. Yeah.
Yeah, just because of the distance problem.
Right.
Yeah, radiation probably is easier for the distance side of it. I love using intravitreal methotrexate. There are complications with it, but these patients are exquisitely responsive to methotrexate. And I actually think, I'm probably going to get yelled at, but I think the regimen that's talked about is too much. I don't know if you need
I don't think there's great data that says that you need it that frequently.
I found that, doing it weekly and then doing it, and then tapering it down to like kind of as needed after you get response, especially those who are in systemic therapy, they do pretty well.
So she's now done with the systemic therapy. She's done with the methotrexate injections, and I'm watching her for any signs of recurrence.
It's cool.
Yeah.
Fingers crossed.
So we'll see how she does.
2025 in the other eye. That's great.
Well, 2025 in the hand motion eye.
Yeah, no, that's what I'm saying. 2025 in the left eye is pretty amazing.
Yeah.
That's great.
And I know, Sunil, we always sort of talk about lymphoma as being not very much of an exudative disease, right? So how often are you seeing CME in lymphoma?
So it's a great question. So usually when you see it is the setting of pseudophakia, but in patients who've had chronic disease, right, there is an inflammatory component of lymphoma because there's an inflammatory reaction to the lymphoma cells. So patients who have had it for a longer period of time, those are the ones you'll see CME.
And the reason you don't typically see CME is most of these lymphomas secrete a high level of IL-10, which IL-10 is suppressive of IL-6, which IL-6 is what drives the CME in these eyes. So typically, that's why you don't see it. But if you were to do IL-10, IL-6 ratios, the ones who have CME have higher IL-6.
Yeah.
Interesting.
So we'll finish with this last case.
So the case they'll go with. I actually don't know.
We'll switch gears. So this is a 48-year-old male with chronic iridocyclitis. He's got a 7-day history of redness, pain, photophobia, tearing, burning, and blurred vision. He gets 1 to 2 episodes per year, and it subsides within 3 days usually, but it's always his left eye. And he's seen by an outside primary ophthalmologist who ordered prednisolone drops, but the patient never got them. He's uninsured, and he has access issues significantly.
So is it basically, it's almost like not really a chronic iridocyclitis then, right? Because does he have full remission?
It's recurrent.
Yes.
Yeah.
Recurrent,
Right.
yeah.
So it's recurrent.
I like you calling out Sumit for calling it chronic when it should be recurrent.
Oh, just wondering if this person gets totally quiet in between.
We don't know.
Oh, we don't know.
So
first time.
So if it was the first time we're seeing him, we don't know if he gets quiet completely in between.
Okay.
So yes, you're correct. The technical
But the
definition is he'd have
symptoms
to be
are-
quiet completely in between.
Right.
But his symptoms are there.
Yeah.
I still
So
think give you chronic because it's duration of more than 3 months
Yeah.
that they've had a history of. Anyway, go ahead.
yeah.
I'm on your side, Sumit.
His review systems is significant for chills, lower back pain, tingling and numbness of his fingers, and depression. He's a type 2 diabetic. He's had tongue surgery, which we don't know what that is, but and a deviated septum, and he's had LASIK in the past. So he's 20/20 in the right eye, 20/40 in the left eye, and this is how he looks. So he's got a hypopion, he's got fibrin, he's got a nearly secluded pupil. It's stuck down completely. And he is very, very active. And Corinne, this is your patient, so you want to tell us your thought process?
So I took a look at him. He looks like an HLA-B27 patient. And I thought TPA was indicated this time to break the synechia and get rid of the fibrin.
So the acute fibrinous reaction and then this synechiae, and how long was this? Like 24 hours, 48 hours, you think it's been going on?
I think it's been going on for a couple of weeks, right?
A couple weeks. Kareem, what's your timeline for what's the longest, someone that looks like this and this started 6 weeks ago, would you
No,
still
I
give
think that TPA is indicated within a week.
within a week?
Yes.
Very good.
This looked very fresh, and he
Yeah.
has a very acute iritis with a hypopion.
So it's interesting. I've have a patient that I've used it in who had symptoms for about a month, and it worked, and it broke all of her synechiae.
So the goal is the goal to break the synechiae or to ultimately prevent the horrible complication of Bombay?
I want to get rid of the fibrin plaque on the lens,
So
because that would usually
Diminish
just
the
stay.
Right.
Okay.
So here's his OCT at the time, but B27 being your most likely thought. So he ends up getting an anterior chamber injection of Alteplase or TPA, ordered Durezol and tropicamide for dilation because there was an issue with cyclopentolate was on back order, atropine was on back order at the time that he came in. So it was tropicamide was your only choice. And here's how he looks after the TPA.
Pretty cool.
A week later?
No, I think this is actually
This is
quicker.
2 days later.
No.
2 days later.
This is 2 days later.
That's so
well,
good.
usually it clears within 30,
30 minutes. 30
But
minutes
he
you
did
get look
not,
better.
so I had him come back in 48 hours. I was totally shocked because he never picked up his Durezol.
He never picked up his drops at all.
What?
So this is just TPA effect.
No way.
Always remember, B27, right, is
Can
the
remit.
classic
Yes.
disease that can go
And he-
very active and
yeah.
very inactive, right?
And he describes it, right? He says the symptoms usually go away in 3 days.
yeah. So
But it wouldn't. The synechiae wouldn't go away.
Right, no,
that
I
was
mean,
the
the
TPA.
TPA
The fibrin
clearly-
wouldn't
Well, I'm
go
just
away.
thinking about how beautiful
Yeah.
the visual
Yes.
axis now looks. You
Yes.
know?
So everyone should use TPA.
So there's some data that TPA may actually reduce inflammation itself too. And so this was very interesting. You know, I've used it more for the synechiae, the fibrin component of things, and I've had a response up to a month out for synechiae. That's the longest I've tried it. I kind of want to try it longer term now.
you
and
need to
see
do
what
a clinical
happens.
trial, right? I mean,
Yeah.
it'd be interesting to see, putting patients on intraocular, to do it. It's impressive how fast it works. I think
Yes.
that the real advantage is, as you said, Yasha, and as Corinne said, is getting rid of the fibrin and getting rid of the synechiae to prevent Bombay down the road, right?
But it's amazing how fast it works. You can just sit and look at them at the slit lamp, and over about 15 minutes, these things start breaking up.
Yeah. It's funny because I feel like this is a very common presentation, right? And yet a lot of them, the ones who are at least very compliant on their treatment end up doing pretty well.
Yes. Right.
When they have fibrin on the lens,
Yeah,
when
but
they have hypopia.
they have to use the drop every hour.
They have to use it every
and
hour.
it takes 2 weeks before you actually see
Yeah.
that kind of improvement.
And the synechiae don't always break in
Yeah.
those.
And arguably, how many of you are putting this person on oral prednisone at the time in which
So
they're coming
if
in?
they came in like that, I'd put them
He's
on.
diabetic.
Yeah, I mean,
He's a type 2
diabetic.
Oh, he's a diabetic.
and he's
diabetic,
not great
I would-
control.
yeah.
The other thing is he has back pain. So do we know if he's had an MRI of his spine? Do we know if
He
he has
has not.
ankylosing
He
spondylitis?
is uninsured.
He's uninsured. He can't afford even the B27 test.
But he's got ankylosing spondylitis.
He does. You know he does because he's got the very classic presentation of it.
We also has like a lot of pan-positive symptoms on his review
Yeah.
systems. Yeah,
Absolutely.
but yeah, absolutely, yeah.
Yeah. But I was amazed at how much he improved with just the TPA. It's incredible.
I wonder there may be a program for uninsured patients, right, to get Humira. So
Oh, yes, there is.
There
if
is.
they
We
have
have a
no
lot.
insurance, I think they can get it. If they have
If they have
lousy
insurance, it makes
it
it
actually becomes
terrible.
harder. Yeah, because we've run into this problem at Bellevue Hospital. So, and I think this is somebody who I think would benefit tremendously from.
If he shows up.
Yeah.
That's the biggest challenge with these.
Yeah, he hasn't come back.
Well, thank you all. Thanks for joining us virtually. There's going to be a question and answer period coming up here, and we'll be happy to interact. So please put your questions in. I want to thank my colleagues here, starting with Yashamoni. Thank you, Sumit Sharma, Corinne Lauder, and the empty chair of Dan Martin, who had to run off on us. Any last words, colleagues, about uveitis and what we've talked about today?
I feel like we need to do this more often. This is just awesome.
All right, Yasha's coming back to do this more often. Sumit, anything you'd like to
Finishing with my usual, please don't inject steroids when you don't know the diagnosis and rule out syphilis and viral infections.
That's a lot to say. One mouthful.
Totally agree with Sumit.
Totally agree with Sumit. I can't disagree with it. It's coming up on the holiday seasons. I hope everyone here is healthy, safe, and gets to spend time with some loved ones and important ones, and we all get to see each other live in person soon. Thank you very much. Thank you, Sean. Good evening, everyone. Thanks for joining in through the magic of Zoom. We've been transported into our homes at this point. Thanks for joining in on right before holiday season, when many of you probably are either ready to go on vacation or just COVID tired. So have Yasha and Sumit. How are you guys doing?
Great.
Doing great.
So, if you do have questions and you're still with us live, thanks for staying with us. Please feel free to ask questions. We're still going to take questions live. It is December 22nd, so I'm just telling everyone here so you know we're here. If you are in full screen mode, go out of full screen mode. There's a little box in the bottom that you can type in some questions. So let's hit some questions here, if you don't mind. A lot of interesting stuff that people have asked. One thing that's come up right now is how long for prophylaxis for toxoplasmosis. So let me give you both the scenario. So I have a patient who had macular involving disease in one eye, and probably let's just say they're 20/80, and in the other eye they have a toxoscar that's not necessarily in the macula, but they have a toxoscar. Pretty concerned about getting disease. What would you use for prophylaxis, and how long would you treat? So Sumit, how about yourself? How do you counsel these patients?
So my general rule of thumb is if it's macular threatening, I will use prophylaxis, or I highly suggest it. And I tend to use Bactrim DS once a day for 3 times a week. So Monday, Wednesday, Friday is kind of my primary prophylaxis for toxoplasmosis. And my counseling is that I don't really know. There is no clear end goal in sight, because if they have macular threatening disease, the problem with toxo is it can reactivate at any time. So I tell them that we're going to consider long term. How long that ends up being, there's really no end goal, and I haven't really found a better way to do it than that. The challenge becomes in cases that are sulfa allergic and have true sulfa allergy. What do you use for prophylaxis there? And I've used azithromycin twice a week at 500 twice a week. And because of the pharmacokinetics of the drug, I think that is okay. And that's more from the ID folks and their recommendations, but I don't have a great alternative when they're sulfa allergic. Yasha, do you do anything different?
No, I think like in the case that Sunil described, where it's macular involving in one eye and then non-macular involving in the other eye, you can sort of, in those sulfa-allergic patients, I may give the patient the choice. In the case where it's bilateral macular involvement, it's really hard to go and say that they shouldn't be on toxoprophylaxis for life. There's some data out of Brazil sort of supporting that there is diminished rates of recurrence with prophylaxis, and so there is value. There's tangible value in the prophylaxis. But again, it's really hard to tell a 30-year-old to take it for 60, 70 years. So what's your thoughts on?
Yeah, this is such a great question, and I think there's fatigue from patients. So what I tell patients immediately is, we do it for like a year and then we see what happens. Most of the data, most of the studies have stopped at like 2 years, so we don't have 10-year data. I do have a number of patients that have kept with it, 5 years into it and such. I do think there are patients who just, after they've kind of been treated for a while, they're okay. And they say, okay, let's just see what happens, because I do think the risk does go down as time goes on. So I'd say for most of my patients, it's a 1 to 2 year prophylaxis. And then I kind of readdress it with them. But I don't think there's a right answer here. I think if it was me and I had lost like all central vision and I had just the other eye, and I didn't have a toxoscar, I don't think I would do anything. If I had a toxoscar that was not macular in the macula, I probably would treat it for a little bit of time. But I think it actually is going to bring up something I want to chat, like take this to the next level of acute retinal necrosis and using prophylaxis there, because I think it's a different animal. But to me, it's, a 1 to 2 year phenomenon. So on that note, let me just talk more prophylaxis as we're here. So let's just say you had a monocular acute retinal necrosis patient. Let's put him at, Yasha's age, so like 12. So somebody who's young, let's make him like, 30, 35 years old. Yasha, how do you have HSV, known RN that occurred in one eye and, hasn't had it in the other eye. Do you prophylax those patients?
For life? Yeah. I think that that's a much easier, like ARN just rips through an eye, and they're, at least in the other eye, we know that toxo is typically reactivation, and so it's a game of real estate in toxoplasmosis, right? How close is it to something where if it recurs, that you're going to have permanent damage as a result of it? So if it's sort of mid-peripheral lesion, I may be very, very less aggressive. ARN, on the other hand, you can very, very easily fall behind the eight ball, even with excellent treatment. They can go on to retinal detachment, and they can have very poor visual outcomes. And so to take, people take Valtrex for cold sores for years. So I think that this is a pretty easy, I've never had a patient who said that they wouldn't take it for life.
How about you, Steve?
Yeah, I agree. I think, I always look back to this one case of he's a 32-year-old healthy guy, gets it in one eye, has severe disease, gets the retinal detachment. We fix it all. And he did prophylaxis for about a year. And about a year later, he stopped on his own. And maybe 6 weeks after stopping, he calls and comes in with a blurry spot in his good eye. And he's got a little spot of ARN right in the macula. Just missed his fovea. Luckily, we got him back on high dose oral antivirals and injected him, and it just remains that little spot. But that is my key to you're on it for life. And so I've kept these patients on for life because he literally recurred right in the macula with having nothing in that eye in the first time.
Yeah, I think that, Sumit, you and I think are aligned, and I think all of us actually are aligned on this. I mean, we have a paper from a couple of years ago that we showed people like 8 years, 10 years later in the other eye getting involved. It's crazy. Clearly, there's a predisposition to this disease, and I think the data on like how effective it can be in other diseases for prophylaxis, not necessarily herpetic retinitis, but other herpes complications. It makes a lot of sense. So for life, 1 gram a day for the rest of your life. Check your renal function often. A couple other questions that are coming up here. Let's specifically kind of address preferred treatment. Oh, sorry. Let's talk about TPA for a second. There's a question on that TPA case. Again, great case. It's amazing that happened, that we got improvement without having to use any steroids. So specifically, Sumit or Yash, if you want to talk about it, how much TPA do you use? How do you do it? Like if you inject TPA into an eye that has fibrin in the AC, if either one of you wants to comment on how your preferred technique.
So I'm happy to. I've used it a number of times, and what I usually do is get the 12.5 micrograms per 0.1 made up by the pharmacy, and we inject 0.05 of that right into the anterior chamber, and you don't have to tap them, you don't have to do anything else. You just do that right into the anterior chamber with a 30 gauge needle, and it works great. So they get 6.25 micrograms into the AC, and you can watch it at the slit lamp over about 10 minutes, breaking down the fibrin, and things get looking better the next day. So even the same day, they often look better. The big keys for me are if it's within 2 weeks of symptom onset, so it has a great chance of breaking all the synechiae and improving the fibrin and everything. Once you get past the 2 week to 4 week window, you still may get some improvement, but past 4 weeks, you don't really have a chance of breaking the synechiae. But if they have a big fibrin clot that's just sitting right on the pupil, right in the pupil, I've used it there, and it's done a good job of getting rid of the fibrin.
Josh, any difference when you've used it?
I haven't used it, and when I saw this case, I was just sort of like mind blown. I was like, oh, "This is kind of awesome." But so to me, I'm waiting for that case. I have my pharmacy on.
You're on standby.
And we use this. It's the same dilution that we use for subretinal delivery when we're doing displacement. So I think a lot of pharmacies have it, and that response is just stunning. So yes, I am waiting for that case for sure.
Great. All right, let's keep moving on here. One of the other questions was with regards to talking about patients who have infectious uveitis and still have persistent inflammation despite that the infection has been taken care of. I'm going to give you a made-up scenario in a second, but let's talk about how you would treat that patient for things like cystoid macular edema maybe Vitrectomy, and we can start with something that we all know, immune recovery uveitis, right? So that's probably an easy place to start because those are HIV patients who immune recovered. So how do you? Let's start with that, and then we can go to something like fungal endophthalmitis that you've treated, and now has CME afterwards, or like P. acnes that's treated. So Sumit, you want to go first here? I mean, I'm happy to start here as well. But how would you approach this? What's your method?
I think the first thing is making sure the infection is actually treated. And
Always
I think
a
we
good
can
thing.
often be fooled. In the syphilis cases, I will recheck RPR titers and make sure that they've trended down. If it's a toxoplasmosis patient, I'm making sure they're still on their prophylaxis treatment, or if they're still showing any signs of activity, making sure that that activity is completely controlled. But afterwards, I am always cautious. So I'm always cautious putting steroids into an eye that's had an infection in the past. So I'll consider topical therapy. So I really like topical difluprednate. I think Durezol works amazingly well in most of these patients. It is now generic as of last month. And so the price has dramatically dropped from
Still
where it
$100.
was. No, so apparently you can get it for $40 now.
Really? I was having
Yeah.
problems with it. I was getting it for 100. I didn't realize it was 40. Okay.
Yeah. So apparently a patient told me you can get it for 40 without any of the coupon programs, without anything. You have to make sure to ask for the generic and not the brand, because not all the pharmacists know that it's available as a generic yet. So a lot of the pharmacies are still ordering the brand name. And the brand has dropped its price, but the generic is much cheaper.
Good to know.
So that's one good thing to know. And then if they show good improvement with the Durezol and there's still signs of activity, then I'll consider local therapy if I want to, if the patient still desires it. And I've done intravitreal steroids, but under being very sure that the infection is well treated.
Yeah, Yasha, how about your comments? Anything you do differently?
Totally agree with everything. I think it's a bit infection specific, where depending on how aggressive I would be, like, for toxo and ARN, we probably treat the infection and the inflammation simultaneously. So they're getting Valtrex. I think one question is, what's your dose of Valtrex for ARN? My dose is, typically 2 grams 3 times a day. That's a high dose. You really have to be careful following their renal function. Probably, I draw blood a week after I start, and then 2 weeks after that to make sure that the renal function is doing well. And then, those patients probably go on 60 milligrams of prednisone, because the inflammatory response is just as concerning. But then there's cases like, immune reconstitution uveitis in the setting of CMV. I would never put an intravitreal steroid or oral steroids on that, because reactivation of CMV is a concern. And then, like Sumit said, probably the real crux of this all is, did you treat the infection completely? And are we 100% sure that there's inflammation only? And that's a really hard thing to parse out.
Okay, I'll give you the old man talk on this one. My perspective is exactly the same, but I'll use oral steroids. I'll usually talk in the setting of someone who has HIV. I'll talk to the ID doctor first and make sure that the CD4 count has to be high. I'll watch him carefully after I start him on oral steroids. I try difluprednate first, and then if oral steroids works and I can't maintain them for a while, then I sit here and decide IMT versus one intravitreal. And if I'm going to do intravitreal, I'm going to watch him like a hawk. I'm going to put something in that I can take out. So we used to be able to try Essence. I mean, I think it's easy. Dexamethasone's easy. Both of those I think work for all of us. I don't like periocular steroids because I can't get rid of it. So I don't use perioculars because you can never get rid of it. So if you're going to go put something in the eye, I would prefer an intravitreal triessence or dexamethasone. Personally, that's me. And Yasho, I think one of the other things that you mentioned, I think one of the questions was, what's the prophylaxis dose for acute retinal necrosis? I use 1 gram a day of Valtrex. I've also used 500 milligrams. How about you guys? What's your dose for someone you're prophylaxis, Yasha?
Both based on body size. If they're under 60 kilos, I'll use 500. If they're over, I use a gram. There's no science behind this, unfortunately. I don't think there's great data supporting prophylactic dose.
Yeah, I stick with a gram once a day, and that's kind of my prophylactic. I've switched my treatment dose though to what Yasha said, which is the 2 grams TID instead of the 1.
Yeah, I'm still 1 gram TID, and I give them intravitreal antivirals, but I
You
do
do
1 gram a day.
gram.
Yeah, I just do it to be obstinate at this point because I'm like the only one left who's doing it.
Your
But
partner wrote a AAO perspective on this.
I
At
know, I
2
know, I
grams.
know. There are a lot. There's zero data on the comparison, and I'm putting intravitreal on every single one of my patients because I have access to it, and I want to shut this thing down. The point of treatment of acute retinal necrosis by mouth, right, is to obviously stop the infection, but it's also prophylaxis for the other eye, right? So at a gram TID, you're going to get up to the where you need within a few days. 2 grams may get you there a little bit faster, and maybe get you a little higher dose. But if I'm giving intravitreal therapy, I'm not so sure there's a difference. That's my perspective. I'm not saying anyone's right or wrong. Having now seen 3 patients go into renal failure, I have been quite, just cautious with it. So that's all.
And
I
the
don't
renal
think I
failure
wouldn't.
can be bad.
Yeah, and I wouldn't
Yeah.
argue with you guys and say, hell, you do 2. I don't yell at the fellow or anyone who says I put them 2 grams. I just try to get them off of 2 grams quick. Like once I start them on 2 grams, how long do you really need to be on 2 grams, right? I mean, I think that's the next question because we actually don't know how long. So we've done this for, well, if you look at a lot of the data that's out there, I mean, retinitis probably, it takes a couple of weeks before you see retinitis actually become inactive. But do you have to stay at the high dose for that long? And I don't think that's clear to me. I don't think you need to. Personally, I think you need to treat them probably aggressively for a few weeks, and then you can back off the dose. But that's my opinion on this.
Yeah, and that's
Go ahead.
definitely a drawback, right? I think we've all probably, that's why I check labs so frequently. I certainly have cases where if you're putting somebody on 2 grams 3 times a day, you will cause AKI, you'll cause acute kidney injury. But I don't know if I've ever had anyone, like nobody's gone into renal failure. I think I bumped creatinines up to 2 and then had to backtrack very quickly.
And AKI is probably the better definition. I don't think I've someone into frank failure where they're actually, I take that back. 1. Yeah.
I gotta say, I had one from outside that did not do well. So they didn't monitor her
this is
kidney
the
function.
same case. This is the same case.
And she ended up in the ICU with altered mental status and did not do well. Was in the ICU for over a month because of the kidney issues and the accumulation of the toxic byproducts of the breakdown of the cyclovir. And so it is something to be afraid of. It'll give you more gray hair and you'll be very cautious. So I'm at 2 weeks of 2 grams and then you're coming down to the 1 gram after that. But I'm watching your labs the whole time like a hawk.
Yeah, and again, I think 2 grams makes a lot of sense. I think there's lots of, especially if you don't have access to intravitreal therapy, I think you can make a very clear argument. But remember, outcomes in this disease are dependent not on the dose, it's on how quickly you treat them and how extensive the disease is. Those are the biggest predictors, not the dose. No one's ever shown dose makes a difference in any of these things. Let's go ahead and great discussion. One question here about intraocular lymphoma. I think it's actually a really nice one about, have either of you seen resistant to both intravitreal methotrexate and rituximab? And when do you call it resistant? Do you have to a couple of how many injections? And if you don't have a response to intravitreal, what do you do afterwards? So I mean, I'll just start with my opinion. I actually don't think I've seen this, resistance to methotrexate and rituximab, because I think I've seen people who haven't been able to tolerate methotrexate simply because of the toxicity associated with frequent injections. So I'd say that if somebody wasn't clearing with intravitreal methotrexate, I would, number one, just make sure how much I'm giving, how often am I giving it. And I do think that these patients, you have to treat for a very, 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 very long time. And sometimes, if you look at the recommendations, it's very aggressive therapy in the beginning, and then you kind of taper off. I've kind of moved myself to like treating them and watching them and treating them as needed. So some of these patients need frequent treatment. Some of them need like a treatment that's like, every month. And I think my basis of what to do really is up to the patient. If they say, I'm sick of this, I go to radiation. Systemic therapy versus radiation, we can have that chat as well. But let me allow you guys to get a word in here. Yasha or Sumit, any thoughts on this?
For you. So then maybe can you just go over the coli algorithm? I know there's like a basket one, and every group has a
Yeah.
slightly different strategy.
Can I just say that I would rather not say that there is an algorithm on this. I don't think I think this is something we have an active discussion on, because I knew Arun Singh, who's our tumor specialist, you know, super intelligent and like knows this stuff really, really well. I think we all disagree a little bit amongst the 3 or 4 of us who do this. So I think, traditionally I started off with the twice a week, recommendations for a couple weeks, then going down to once a week, and then every 2 weeks, et cetera, et cetera, et cetera. What I find is the limitation there is toxicity without really any sort of gain in improvement in vision, really. So the real question you have to ask yourself is, what are you treating? Are you treating local disease only, or do you think treating it locally has an impact on systemic disease, which I don't think it occurs. This is where the argument part gets fun, because then the question is, does treating them, if they only have local disease only, impact, if you treated them with systemic therapy, does it impact their lifespan? And this is where the fun begins, because we disagree about this stuff a lot. And I don't know the right answer. I rely on my colleagues in neuro-oncology to help us make these decisions. But let me, Sumit, what are your thoughts?
Yeah, so I think we go back and forth on this, and a lot of this fluctuates based on what neuro-oncology is saying too. In that, when I first started, I think the general trend was, without documented CNS or extraocular disease, either by MRI, high volume LP, that they were not doing systemic therapy. I think more recently, we have actually shifted more to, if they have bilateral eye disease, there has to be some sort of CNS involvement. And at least our neuro-oncologist is more willing to treat systemically in the absence of documented CNS disease, as long as there's documented bilateral eye disease. So it goes back and forth, and I think it depends on the individual patient and how well they'll tolerate treatment as well. But again, there's no good data on this. There's no good data that says one way or the other, should you go and treat for systemic, does it increase survival or not? And I don't know the answer to that.
Yeah, because I think that's what we're trying to do here, is like survival, right? So local disease, right? It's vision, right? We're trying to preserve vision. I don't think we impact survival. So for me, how I do it is I give someone intravitreal methotrexate once a week. I bring them back and see how well it cleared. If I cleared them, then great, I'll give them a second one, and then I can just start like doing it and seeing how often they need it. So I follow these patients very carefully. Some of these patients travel incredible distances and can't do that. So those patients, we talk about radiation, if they just have local disease only. But we all now have a bigger discussion for the patient. The patient actually makes this decision on whether or not they want to do systemic therapy for local disease only. So I wish I could tell you there was a correct way. I think each institution does it a little bit differently. And I don't think I can argue with any way. I really think you have to have this discussion for a long time with the patient. So, in answer to the question that, was brought up, if I had somebody who required a lot of injections and couldn't tolerate either the side effects or the number of injections, and they still didn't have CNS disease, I would probably offer them radiation, but I don't think it's unreasonable to offer them systemic therapy either. So it's a really great non-answer.
I think it really highlights that we don't know, right? And it has to be tailored to the patient with a discussion with the neuro-oncologist. And you got to take lifestyle factors into account, because unfortunately, long-term survival for this disease is not great. And long-term survival at that point it is our goal, but 10-year survival is not good for CNS lymphoma. And so if you have a young patient with bilateral eye disease without systemic documented involvement, maybe you're making a little more consideration to giving them systemic therapy, but then there's the downsides of giving a young patient systemic therapy. So this has to be tailored to the individual patient.
Okay, let's move on to another question that came up on treatment of fungal endophthalmitis with voriconazole versus Ampho. Yasha, what's your, somebody, Canada, has vitreous disease, and you want to give them an intravitreal injection. What do you use? Use Ampho, or do you use?
I use Ampho. The half-life of Vori is in the order of a few hours, and so I think just as a result of that, I know that I have a longer effect from Ampho. But yeah, what do you guys do?
Sumit, how about you? What do you do, man?
So I go back and forth, and the reason I go back and forth is I talk to ID first, and I see what they would recommend in that case, because I've had a couple patients now where I agree the vitreous half-life of Ampho is longer. The spectrum of Ampho is a little bit broader, so I was using a lot of Ampho. However, now I've had a couple patients with either Candida gyromondi or Candida lusitiniae now, where their in vitro sensitivity testing will be sensitive to Ampho, but for some reason that's not fully understood, in vivo, they're actually resistant. And they recommend Vori in those cases. So I have a discussion with the ID doc first and say, which one would you prefer? And I've been going back and forth based on what they tell me.
Yeah, I've had the same experience where, so I use Ampho first for most of these, and then Vori. I think it just depends on, what the sensitivities are. So I think I'm exactly like the both of you. There are some that I use, Vori on primarily, but I'd say it's mainly for me Ampho. Um, another question that came up here. Oh, sorry, acyclovir. Does anyone use just straight acyclovir for any of the viral diseases? If the patient can't afford.
If you can get Valtrex, the bioavailability is so much better that you should use it.
Sumit, ever
Yeah, I
switched over to
agree.
acyclovir?
I mean, only for cost reasons, and it's then you're doing the 800 5 times a day, and you're still having a lower bioavailability than the 1 gram 3 times a day with the Valtrex. So I try to push for the Valtrex.
I've used it in patients as I've been using for prophylaxis. I used to, again, old enough to have used IV acyclovir in patients in the hospital and then put them on acyclovir afterwards. Challenging, but it can be done. It's not perfect, but it can be done. Let's try to hit 2 more things and then we'll close up because I know we're running out of time here. Dose of intravitreal for methotrexate. I use 400 micrograms. Anybody use anything different? Same. Okay, very good. Make sure you're looking at the methotrexate so you can see what the color is. Make sure it's truly 400 micrograms. You're not getting too much of it. It does cause pretty significant surface toxicity when you're out of it. There was a question here about using letermovir for CMV in patients who can't take encyclovir. I believe it's on label for prophylaxis of CMV in patients who are like transplant. I believe it's like bone marrow transplant. It might be liver transplant. I can't remember actually. Has anyone used it here for active CMV retinitis? So I've had one patient we've used it on in an HIV patient because of this ganciclovir issue that was brought up by the person asked the question of cytopenia. It didn't work great for me. I ended up having to use a fair amount of intravitreal therapy and kind of ride out to immune reconstitution. So I didn't have great success. My N is 1. So please take that with a grain of salt for the person who asked the question out there. I didn't have great success with it. So, and I think the data out there for active CMV retinitis, I'm not sure, is very, very clear. I think we've hit, anyone who has used CAR T therapy for lymphoma for their lymphoma cases. I see Sumit shaking his head no. And Yasha's giving me stop asking me this kind of question. Yeah, no, I haven't either. We haven't gone down that road yet. We here at the clinic, we haven't had that use. So I'm sorry, I'm not going to give you a good answer here of like treating ocular disease with CAR T. We haven't just seen it yet. And I think we hit everything else that people asked. So that's great. Some great questions, some great responses. Just for the audience out there, we're doing this again. We actually had a lot of fun. Actually, it was mainly just hanging out with Yasha. I think maybe made it the most fun. Oh, Sumit, of course, as well. But we are planning on trying to do this a couple times a year. In 2022, we're trying to plan it out. Who knows what's going to happen? Whether we can see each other again. But we're going to do this again. I hope you all enjoyed it. You'll be getting a link for CME from so please look out for that. If you have any comments, we're always happy to hear them. We try to make this better. This is for the audience out there. Thank you for hanging out with us. Yasha and Sumit, thanks for chilling with us and chilling with me. Any final thoughts? Yasha, I'll give you give you the first word here, buddy.
No, happy holidays to everybody who's listening. I know it's pretty late on what day is it even? Actually, I don't even know.
Wednesday. It's Wednesday.
So really, thanks to everybody who made it to the end here.
Sumit?
Yeah, I'll echo that. Happy holidays. Everyone stay safe. Everyone please get vaccinated if you're not, and get boosted if you haven't already.
I echo all those things. And it's always fun and to interact with everybody here. We're just this big family of ophthalmologists throughout the world who are trying to take care of people. And if we can share some fun cases and have a good time doing it, I think it makes the education really enjoyable for everybody. So please, again, let us know what we can do better, and we'll try to aim for that. Have a great night and good holidays.